All right. So with that, I'm going to go ahead and turn on the recording. I'm going to go ahead and change the meeting chat so that it's only set to chat with the host. And I will again welcome everyone to this evening's virtual AMCSI conference. We are in day 6, if you can believe it. My name is Jean Ballant, and I will be serving as a technical moderator in the background for our session. Now, we have a number of guests who are currently checking in to join us online. And while you all get connected, we'd like to walk through just a few quick housekeeping items to make sure that everybody understands how to participate. For those of you who have been with us all week, I'm sure you know these, but we have a couple of people who are joining us for the first time this week, so we want to make sure everyone knows what to do. Our session is being hosted live on Zoom and Facebook, so you'll be able to watch or listen on any device with internet. And for those of you who cannot use Zoom or Facebook, remember we do have a call-in option and you can simply listen on the phone. Everyone is muted when you join, and we ask that you remain muted to cut back on any unintended audio disruptions. I will remind everybody that we expect a wide range in viewers this evening in terms of ages, so we just ask you to keep your comments and questions respectful, considering that we may have some younger viewers on the line. If you have a question, a comment, or need to report any sort of technical issue, the meeting chat will be available throughout the entire broadcast in Zoom. It's been set to only allow you to chat with the host. So if everyone could who's been connected, go ahead and open up the meeting chat right now, find the technical moderator, Jean, that's me, and send me a direct message. I would love for you to say hello, let me know where you're connecting from or how excited you are, whatever you wish to say. And while I'm waiting for those messages, I will speak to our friends who are watching out on social media. You can actually send messages into the comments on the live video, and we have moderators who are watching over there who can relay messages back to us here in Zoom. So no matter how you're watching, you have a way to communicate with us. And I see those hi messages. That's excellent. Thank you. So I encourage you all to use that chat to ask your questions and share your comments with our presenters at any point. We're going to pause for Q&A breaks later, but there's no reason to wait. As soon as you want to, put those questions in, and then that way we can try to get through as many questions as possible. Our session is being recorded, and we'll be posting them on the AMCSI website and YouTube after our virtual conference is over. So everybody has been in a Zoom meeting, hopefully, but just in case you haven't, remember if you're on a computer or laptop using the desktop application or even a web browser, you'll likely see a screen like this. There'll be a series of controls along the bottom. Your audio and video controls will appear in the lower left, and then you'll be able to see the shared content in the main portion of your screen. There are additional controls on the bottom middle where you can open the chat, look and see who else is joining. And then, as I said, use that chat sending messages to me as the technical moderator if you have questions or comments. Our video for our speakers should appear on the top, but there are some additional controls, including gallery view, speaker view. You can change things around. I encourage you to play around with the settings. You may want to use full screen. You may want to zoom in further. Do whatever works best for you. For those of you on a mobile device, you have many of the same controls, just know they're in slightly different places. So you'll still have those audio controls. You'll be able to open the chat, and if that button doesn't appear on the bottom, look for a 3 dots more button. Oftentimes the menu options that you're looking for are hidden over there. And then in a mobile device world, it's oftentimes swiping to the left or the right to change the layout on your screen. All right, I think I've covered all of my technical reminders. I think this audience is ready to go. So with that, I'm going to turn it over to Joey Ballesteri to take things away. Joey, why don't you get started?
Thanks so much, Jean. I'm so excited, y'all. So happy to be here with each of you. Thank you so much for showing up today, whether you're on social media or joining us on Zoom. We're just so happy to have each of you here. Want to start by welcoming you all to today's night of our 16th annual AMCSI conference. Although this year, obviously we are virtual and not in person, we are certainly together in heart, even though we're apart. My name is Joey. I serve as the Vice President of the Board of Directors for AMCSI. I've been involved with AMCSI for 5 or 6 years now, first serving in the role of Secretary on the Board of Directors, and then within the last couple of years transitioning over to my current role. I have a 6-year-old son named Liam who is my world and has AMC. As you can imagine, and I'm sure so many of you can relate, has absolutely changed my world, and I love learning new things to, learn how to better support him as a parent. And I am so excited for tonight because we have two wonderful speakers that I think will absolutely change, my perspective on all that's possible that he can do. Yeah, with that, if you want to move to the next slide, Gene. It looks like we are, having our virtual conference. It's going to run every night, the entirety of this week. So we're going into our almost last night. Tomorrow we have a conference, but each of these sessions include two different presentations by a professional in the medical space or someone that's working working to support those with AMC. As you know, if you're here on Zoom, all the registration is required, but it's free and open to the public. And as I think Gina already mentioned, you can access all of these also online live stream across several social media sites. To ensure that we really can track who's coming and really support you all as you're here, we definitely encourage you to continue to come on through the Zoom and actually do a full registration. But there are the sessions that we hosted earlier this week, and here are where we've been the last couple of days. Tonight, obviously, is the 23rd. We have Dr. David Feldman at first, and then Dr. Frumberg a little bit later tonight. Note that we have rescheduled Dr. Reed Nichols. She's going to be joining us tomorrow, Saturday the 24th at 5:45 p.m. Eastern. So that's a bit of a time change in terms of you are all used to joining here at 7 o'clock, which is what we've been doing these last couple of days. And also remember that tomorrow we will announce the location of next year's conference, the 2022 annual conference. So excited to find that out alongside each of you. You certainly don't want to miss it. In terms of our agenda, wanted to go through sort of a quick overview of what to expect tonight. We're going to start with the presentation, a novel approach to increasing the range of motion of the knee, data presented by Dr. David Feldman. Immediately following that presentation, we're going to hold a brief Q&A segment. And note that you're encouraged to send questions and comments to the chat window, as Jean said, through the chat function that we have here on Zoom, but also if you're watching on social media. As Jean said, please send in your questions. We have moderators that are able to really closely watch that and then get those questions to me to ensure that we can present them to Dr. Feldman. Later, we're going to welcome our second speaker. His name is Dr. David Frumberg. He's going to be presenting in particular on AMC adults, hips and knees analysis. We're going to follow that talk again with another Q&A before we wrap up for the night. I also just want to name really quick that there are, several children in the audience tonight, and I just want to provide a disclaimer that there are some images from certain medical procedures that are going to be shown this evening that maybe are not best for the eyes of our younger viewers. So just want to know that and name that going into this meeting, and certainly, give you the opportunity to think through what's best for your kids to see and not see. With that, y'all, would love to tell you a little bit more about AMCSI. So we are a 501c3 nonprofit, and our mission, really is to provide support and encourage more understanding across the AMC community. Anyone diagnosed with AMC, but anyone that also, interacts with a loved one or supports someone with AMC. The goal here is just to create a higher standard of AMC awareness. And that typically happens a couple of ways with AMC. Conferences are obviously one, and it's been sort of the pinnacle, I think, each year of our time together. Obviously, last year was canceled because of the craziness that COVID brought. And this year we're taking all that we learned from last year and turning it into a really wonderful virtual experience that I hope each of you have been able to enjoy these last couple of days. But know that that is not the plan for next year. Next year, we expect to fully transition into real life again, and are thrilled at the potential to all come together and the incredible amount of collaboration and love that brings. So thrilled for next year, but more so, happy that we have been able to figure out something like this and get through all of this craziness certainly together. And I think being a part of AMC over the years and sort of watching different nonprofits across the community navigate really tough times like this, I think we should all feel incredibly proud at the way that we've been able to come out on top. And I know that that is due to nothing else outside of you all, the people out there that are watching and participating, asking questions. You all hold us accountable in terms of delivering the best experience possible. And I'm so proud of Jean and Michelle and the entire Loon crew have worked tirelessly to put this together, and know that as soon as they wrap up tomorrow evening, I want to say they have like 1 week off and then they go into planning conference for next year. So this is a very intense job, and I'm so thankful that we have such incredible leaders behind each of those seats. I think I'm done rambling for a bit, but Jean, do you want to launch the poll and see who's all out there?
All right, I have just popped open a poll now to see who on the line is a member of AMCSI. For those of you watching on social media, you can certainly chime in on the comments if you're a member or you hope to be. And while I am waiting for more of you to vote, I remember I can see who's voted in here, ladies and gentlemen. So I know you can do it. You're going to look at that little pop-up. You're going to click on the circle next to the answer that is correct for you, and then scroll down to the bottom and hit submit. And I am just killing a little bit of time while I wait for a handful of other people to cast their vote. There, we have crossed the magical threshold, at which point I will now close the poll down and let's take a look. So Joey, when we started this conference, not a lot of people were saying yes. A lot of people are saying yes. So
I think that speaks to the quality of this conference, Jean. I'm so impressed at what we've been able to put together, and so thankful to be a part of this. But it's wonderful to see so many AMC members out there, guys. Thanks for joining. It truly means so much for our work. For those of you who are still interested in joining AMCSI, maybe you haven't gotten around it, it's been a busy week, please look for a link in the chat from Jean. She's gonna send that out. And then also note that our members get all of the major discounts and early bird access when you register for AMCSI events and obviously next year's conference. So exciting stuff there. There are a couple more ways to help though, which I'm excited to walk you all through. So in a very serious note, we would certainly not be where we are today in every sense of that concept without people like you and the support that you've given us, whether that be emotional support as we come together as a family to get through something difficult like COVID, or ultimately all the wonderful support that you've given us to sort of allow us to operate, provide grants. Hopefully you were able to attend the kickoff event where we had our open board meeting a few days ago, Sunday night, I believe. And ultimately you got to hear sort of some of the grants that we're able to give to our community and how powerful and those experiences can sort of become true after something like that. So please, if you don't already, it's fairly simple to, if you're an avid Amazon shopper like me, it's fairly simple to go on Amazon. You have to type in smile at some point, either first or last after Amazon. And then it takes you to a page that will allow you to choose a nonprofit of your choice. There are hundreds, I want to say over a couple thousand of these well-deserving nonprofits. If you search for AMC, you can find us. And then Amazon then directly gives a charitable contribution every time you buy something. The same is true for eBay. So if that's something that you use, please do the same there. But again, just want to really ground this entire conversation, this entire session in all of you, and know that none of this would be possible without your support. And we are so sincerely thankful for all that you do for us. Awesome. I would love to learn about you all tonight a little bit more. We know that there are a lot of members out there that have recently become members, hopefully, and those that are, I'm sure, going to become members in the short term. But let's learn where we're joining from tonight. We have the different sectors across the country posted, and then once you do that, tell us why you're joining. So you might have a child with AMC, which is my case, a partner with AMC, you yourself might have AMC, you could just really love someone with AMC, which I know that probably all of us can check that box as well. When Jean gets those up, I'm excited to dive into that.
All right, so I think the audience has caught on to these polls. So we've got about 3/4 of them having responded. So I'm going to go ahead and lock it down and let's take a look at the results. So Joey, we have swapped back to the Northeast Southeast showing up as our big group of attendees, but we do have a number of international guests joining us today. For those of you who
Wow.
are joining us from outside of the US, go ahead and chat in and let us know where you're connecting from. We'd love to learn more. We do again have a really strong turnout for individuals whose children have AMC, but there are unsurprisingly a number of adults or individuals with AMC who are joining us tonight. And then again, we are seeing a nice additional group of people who either work with, know someone, care for someone, and then some people who are just curious to learn more. So we're great. It's great to see everybody here.
So great. Thanks for that, Jean. Again, we are so excited to have you all here with us online tonight. Now let's go ahead and meet our first speaker. So Dr. Feldman, if you want to go ahead and start sharing your screen, I will talk about you and bring you on. But as you all know, our first speaker will be Dr. Feldman tonight. He's going to be presenting on a novel approach to increasing range of motion in the knees. So Dr. Feldman is an internationally known orthopedic surgeon. For over 2 decades, have been at the forefront for the treatment of complex orthopedic disorders. After over 20 years at New York University as the professor of pediatric orthopedics and the chief of pediatric orthopedic surgery, Dr. Feldman is currently the associate director and leads the spinal deformity and hip preservation centers at the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. He has passionately advanced the treatment of arthrogryposis by innovating new and effective procedures that allow for the restoration and improvement of motion and function in all of his patient population. He recently published a paper on the results of novel approach of increasing the range of motion of the flex knee and arthrogryposis. So I would imagine that has something to do with tonight's presentation. So happy to have you here, Dr. Feldman. Feel free to take it away.
Joey, thank you so much. And I've been to a number of the AMCSI conferences, and this virtual one is obviously second best. We're looking forward to seeing everybody in person. I want to thank Michelle, Jean, and yourself for allowing me to present this, and also just doing so much for AMC and continuing to do so much, where I think there's so much still to be done and so much progress we're going to see over the next several years. So I'm looking forward to it all. Looking forward to seeing you all in whatever. I hear it's not going to be in Alaska, but I do hear maybe in the lower 48 next year. So we'll all find out tomorrow where that's going to be. But thank you. Obviously, Joy would tell me if you can't hear me, so I assume I'm being heard. So I will continue on. So this has become my really the latter part of my career. My dedication is to try to change how we treat certain conditions, and AMC, arthrogryposis, and all its varieties, to try to increase the range of motion, to try to not just straighten limbs, but to make people functional. And one joint that is really a problem is the knee, because having 2 straight knees may allow you to walk when you're 6, but it's very difficult to live with 2 extended knees in our day and age. I'm going to show this video, and I just have no disclaimers to make from this talk. And I have every patient who's in this talk has agreed to allow me to show their videos. So this is a young man who actually came from Poland. That's him trying to walk about a year ago, and that's before surgery. And obviously he has some good muscle strength, but he can't get up on his legs because his knees are very bent. And he has no quadricep muscle. He has no ability to straighten his knee. And you can see that, so he's unable to walk, even using braces, because you can't get a brace on a 90-degree knee. And that's what he had. He had knees that were really flexed, and so he could not walk. He could walk only on his knees, and they were bent about 60 on one side, of range of motion from 60 to 120 or 70, and then the other side I think is a little bit worse. And you can see that there. That's one of our therapists who's now in Boston. He's a terrific guy named Jeff Afferman, and he moved to Boston. We miss him. And this is after surgery. So not only have we straightened the knee, but we've also allowed the motion to be maintained. And that's only 5 weeks after surgery. So I don't cast AMC because I still think that casting above the knee is really a problem. Below the knee is fine, but anything else, the elbows and knees do not like to be casted and they get very stiff. So we keep the motion going from day one after surgery, the therapy begins. And that's 5 weeks. And he's really not suffering in pain as we move his knee forward. And you can see he's about 80 degrees there and about 90 degrees on that side. And that's only 5 weeks. And this is him trying to stand. And we're getting him to stand at 5 weeks. And this is worth watching because this is, watch his progress. And there he is at 6 weeks with Jeff trying to control him. And he's obviously wearing extension braces because again, he has no quadricep function. But he could still sit in a chair, and he could still sit in a car and in a plane, and he could walk independently. And now we are 10 weeks post-operatively, and he's using a 1 cane. He's showing you he can walk without it. And this is him at 10 weeks. And there he is throwing away the cane. And ringing the bell, which is what we do for the kids when they leave our physical therapy, when they leave our care and go home. But obviously we continue to care about them. So, you know, the question is, how do we do that? And I'm going to go through the paper because people have been asking me for the data. So I will talk about that. And I'll talk about the paper. I'm sorry, there's actually a underlying voice here. So, you know, the synonyms for arthrogryposis are AMC, arthrogryposis, amyoplasia, and we all know them. And we know there's associated syndromes with them, and we're finding more and more. We have a geneticist who works with us and a genetic counselor named Abby, who's phenomenal. And we have found that while AMC used to be thought to make up 80% of non-genetic forms, it's probably more like 40%. And we are finding many, many genes that were not found before that are associated, and grouping these patients together and grouping families together and parents and children together when they have different chromosomal abnormalities or a microarray abnormality or even a gene abnormality. That it really is very helpful in understanding what may happen and how to treat patients. So we agreed that arthrogryposis means stiff joints. So if we have stiff joints, then the goal of the surgeon should be to make the joint less stiff. The goal of the physician, the physical therapist, the occupational therapist, to be to make the joint less stiff, because that's what disease causes, is stiff joints. And so you could have hips that are dislocated, you could have flexed, and you could have extended knees, which I think we're just starting to solve now. I could talk about that, how that came about later. And you know that for ambulation, we need less than about 30 degrees of flexion, less than 20 degrees of knee flexion. That's what's needed for someone to walk even with bracing. With bracing, it's very difficult to walk with more than this number of degrees of flexion. And you need a foot that's flat on the ground, relatively, and you need some truncal stability. And if you have quadriceps, that means you can walk with a short leg brace. And you also need to be able to sit. So extension is not so great. If you can't flex your hips up, it's hard to sit. If you can't flex your knees, it's hard to sit in 2021 because there's so many locations where you don't have room to keep your legs outstretched. So how did I get here? How did we get to this point? And I've talked about this before. This is a young man I treated from Italy long ago. And I used to treat these with external fixators and slowly correcting them. And on one side, I did that. And one side, I did this before I really knew how to do this. So this was him before. That was the fixator that we used. And he walked when he went home. He did, but his knee was stiff. And one side I did the external fixator, one side I did this procedure. And that was the first time. And I still know him from Facebook, still lives in Italy, and he's back there, and he's very functional. But I think we can do better than keeping a knee just straight. I think we can keep it bending. So we sort of classified these by whether or not they have quadriceps, 1A. This you don't have to watch, you just saw that. And so this is where the children can, if I'm going to show some surgeries, and that's what Joy was talking about before, that this may not be appropriate for little kids. But again, showing a knee flexion contraction. This is when I was doing one at a time. Now I try to do both in one surgery. But basically you could see I did this in a foreign country, and the knee is straight on one side and bent on the other, but it still flexes. So 90-degree contracture. And so we classified them, whether they're flexed or extended or stiff, and what the hip is doing. And we think that can help us talk in one language. And there's so many interventions, and I know that. There's Therapy, very, very important to get physical therapy and casting, which you can get when you're very young, and bracing and releases, and using those staples to bring the knee straight, which is only good if you have a very small deformity. And then we can talk about all the things that we do. And physical therapy is crucial. So if you can't get physical therapy after the surgery that I do, we can't do the surgery because they make up a big part of what we're doing. And the correct bracing is obviously very important as well, and all these soft tissue releases. And this is that bracing, but it really, I mean, this is that using the growth plate to straighten the knee, but it's really only good if you have less than 25 degrees of a flexion contraction. I think all of the surgeons on your panel and all on your board agree with that. So what do we do? How do we do this surgery in one shot? Well, we loosen up the nerves, meaning that we free them from their scar tissue, free them from fascia, which is holding them, which are like rubber bands, not cut them, but just free them so they can move the joints, then loosen the joints. I don't think you have to put the hips in because the hips will come in by themselves, or I help it at the time of the knee surgery. It's a different conversation. I can answer questions. And then we do shorten the bone of the femur because that helps loosen all the tissues so I can keep it moving. And we shorten it by near the hip, all the way up on the femur. And that's what relieves all the pressure. I can rotate the femur at that time. I can bring it back in if it's externally rotated, and it helps loosen up the tissues so we can keep it moving. How much do we shorten? Not enough to make a difference because the knee is so bent. If it's 90 degrees bent, the child still will be taller, or even a 12-year-old or a 13-year-old. So we do shorten up to 2 inches, even 3 inches at times. And this is a little baby. And when she was a baby, you can see she has good trunk, but she has, knees that are quite bent. But she's able to roll. And that was her trying to walk with big contractures prior to surgery, right? So it's very difficult when you have such bad contractures to try to walk. And there she is, and that's her knee. And this may be a different child actually, but then you see I'm doing one surgery, and this is just showing that the knee, even after the surgery, can still straighten and bend. And that's when one side is done, walking up steps. And this was before, and this is only 6 weeks after. And that's after she's training for Olympics, but basically she can really try to walk really with bending her knees. And obviously she has some quadriceps, and the kids fool me because sometimes I don't think they have quadriceps to straighten the knee, and they end up just walking with AFOs or no braces at all. So it's pretty interesting. So I'm not going to go through the whole surgery, and this is the part that I think I'm going to skip through very quickly. This is mostly for surgeons to try to show them how to do this, but if anybody's interested, you'll see it's a very big incision. And this is when, turn off the screen right now, everybody. There you go. But just believe me, it's a very big incision. I don't have to show everybody that. And if you're interested, I can go back and really show you. But that was the incision. That's after one side is done. So I'm not going to really discuss the hips very much, but just to say I don't think that should be done. I don't think you need to bring the hip out of the frog position first, because the hip will come down if you fix the knee. It comes down. And if you have to help it, then we do releases at the hip. So another young girl who I met at the conference, this is a young little girl who I met at AMCSI, trying to walk. This is her a year later in Norfolk, Virginia, after we fixed her knees. And this is her in Norfolk teaching my wife how to stand. So we were in Norfolk and she's trying to teach my wife how to stand up from a seated position. She does a very good job teaching her. And you can see that, I mean, she's still strengthening here, and there she goes, and she's up. So, and she takes a bow. But basically this makes you functional, and it does work. So I will spend a little bit of time. I've discussed this before, so I'm not going to over talk about this. We do not embrace, we do not cast them. We start range of motion with our therapists as soon as they leave the hospital, and we just put a knee immobilizer on, like a little Zimmer splint or a brace with Velcro straps to help them, just for support. And I try to do both at the same time. So for those of you who've asked me this question before, this is why I'm here tonight, is to tell you, so we did review our results. It takes time. So I just started doing this operation really in 2014. I moved down to Paley in 2015. And we were able to at least follow up for at least greater than 24 months of 39 patients with 73 knees, which was pretty good for our first 73 knees that we're able to get results on. And we're able to show that the arc of motion was 45 degrees before, which means that if you go from 45 to 90 degrees, that's a 45-degree arc of motion. If you go from 90 degrees to 135, that's a 40-degree arc of motion, or 45-degree arc of motion. So the arc was 45 before we started and was 79 degrees when we finished, and they did not lose that arc of motion over time. The flexion contracture at latest follow-up was about 8 degrees. So they started, having, these were all degrees of greater than 45-degree contractures. So the knees were bent all more than 45 degrees. And then we even did sub-analysis of knees that were contracted more than 60 degrees. And there was no difference. And then we did ones we could only follow up for 12 months and 24 months, and they did not really lose range of motion. But you have to follow it. Had to have physical therapy. You'd have to wear bracing at night. So it does take a lot of work. It takes a lot of work for the patient and for the child to do this. So we looked at our methods. We had an IRB approval, and we looked at the different types of patients. The flex type were certainly the most common, and we took the rigid ones that only had about 20-degree arc of motion, and the flexed ones. And I will talk about extended knees at the end of this talk, because I really do think that serendipitously we've come up with a really, really good way to fix the extended knee, which I didn't think was possible before. So these are all the flexed knees again, and that's the treatment. So this is from the article, and I won't rush through this. This is actually a young girl with Escobar syndrome, which is probably, in my opinion, the hardest of all the arthrogrypotic syndromes, one of the hardest arthrogrypotic syndromes to treat, because there's webbing involved. And this we've genetically shown this child had Escobar, previous surgery on her hamstrings, and she was about 9 years old from Chicago and has this 90-degree contracture, 85-degree contracture. And there's the incision with a tourniquet on her leg, showing that I'm releasing the fascia, right? And there's my incision. It's a big incision. It heals very nicely, but it's a big incision. And then basically, here I am, what everybody talks about, what does it mean to free up a nerve? Well, that's what it means. You find the nerve, and then you loosen all this fascia. This white stuff is fascia, and you loosen that up from the nerve. And I know everybody, when I've given these lectures before, you guys love, like really all the different facts. So that's the fact. You take all these fascia, and you loosen the nerve from the fascial bands. And that's me doing that. And then I come across to the inside of the knee, because I've released now the back of the knee, and I make a counter incision on the inside, so I can almost see across the back of the knee. So I can basically release the knee. And now the knee is released. And I've now done that. But if you do this and do all of that, you've gone from 90 degrees to maybe 70 degrees. So that's when, if you're going to put a fixator on, you put a fixator on, or I'm now going to shorten the femur. And that's how I do it. So I put a rod in the bone in the top. I support the growth plate, because I can talk about complications in a minute. I support the growth plate with a rod and a couple of wires. My partner, Dr. Hoosier, made this video, this little drawing for me. And basically where it overlaps, where I can get the knee straight like that, that's how much I shorten. That little end number, that's how I know how much I'm going to shorten, because the knee will straighten on the table while I am doing this. And that's before and after. I put a little plate on and a rod. I put a rod in the bone because I learned that the hard way. And there's the hip stuck. So I unstuck the hip by doing a release of the hip. And this is that same girl with Escobar syndrome. And she's straight and she can bend 110 degrees. So she goes from 0 to 110 right now. So we're certainly getting better at this we were before. And these are the numbers. And this is an open access journal. So all of you can have this journal from, you can all look at this article and read it from children. It's in a journal called Children. And basically you see pre-op, there's the arc of motion, and there's post-op, and even follow-up, we even increase the range of motion. So, pre-op, you have about a 40-degree arc, and again, you have about an 80-degree arc when you're finished. And that's where you're going from. So here you went from an average of 50 degrees to about 95 degrees. Now you go from about 5 degrees to about 80 degrees. And that's the arc of motion, about 5 to 10 degrees to about 80 degrees. There were a couple of kids with 25 degrees, and one child had an 8-plate recently, I've heard. And this is basically just showing that the p-values, meaning that this is statistically significant for increasing the range of motion. and for making the knees straight. And all of you can look at this article and look at this. This just shows kids ambulate, but I knew that, right? We know that we can take kids who beforehand, who could not ambulate, and make them ambulate, even if we just straighten their knees. But they can also sit. They can also bend their knees. And the treatment is pretty quick. They get better very quickly. The first couple of weeks aren't fun, but they do get better very quickly. What about complications? Let me see if I can find that. So we had a couple of wound issues in the beginning. Let me see if I can find that. I think we have a chart. But anyway, we basically had a wound complication in the beginning. We had 2 growth plate injuries that's when I started putting wires also across the growth plate because we didn't want that to happen. And then one person broke before I started using the plate. I started using the rod. So there's been very few, there's been no infections, and everybody has kept their range of motion. So that basically is the article on this. And I'm going to go back. I am going to go back because I do want to discuss this a little bit. And I also want to go slower through some of the things I talked about, but I wanted to go through an overview first. So what about the extended knee? And this is a young child who's 12 years old, and that's as much as she can straighten her knee. So it's extended basically 25 degrees, and she cannot flex it at all, which is a real disability. And I've certainly had patients come into me and want their legs amputated when they can't flex their knee. And obviously that is not an option, or I don't think it's an option. So, and the question is, how do we get the knees to flex? So I used to think that perhaps that the knees couldn't flex because the condyles became very square. The knee became square. I don't think that's actually the problem. So I think the problem is we were treating it incorrectly. So one thing that I was doing quite a bit of is called a Judaic quadriceptplasty. And what that is loosening up all the soft tissues in the front of the knee and getting the knee moving. And I tried different ways. I tried doing it and getting into a CPM machine, which is a continuous passive motion machine, which actually allows the knee to bend. And then I tried casting the knee afterwards to see if I can keep it bent. But all the children either lost range of motion or went from an extended knee to now having a flexed knee they couldn't straighten. And I couldn't find anybody anybody with better results. Like this Judaic quadriceptplasty is a big operation. Most of us are doing that for these extended knees. And even I tried doing it very young. I tried waiting until the kids are older. And then I started giving up, but I couldn't figure it out. And it turned out what happened was I saw a child who was treated somewhere else, doesn't matter, and basically had a ruptured patellar tendon. The tendon that attached to the knee from the kneecap actually ruptured during surgery, after surgery. Now that's bad because then you can't extend your knee. But the interesting thing was that after that occurred, the knee range of motion was great and they didn't lose the range of motion. So obviously it was the quadricep mechanism being ruptured and no longer tethering the knee straight. All of a sudden the child could bend their knee. Now I had to repair the patellar tendon, but I'm like, wow, this is now 3 months post-operatively. They're very upset because they couldn't extend their knee, but the range of motion, which started as being just 0 to 10 degrees, was all of a sudden 0 to 90 degrees. So I said, well, I could do that. I could take off the patellar tendon. Then I thought, well, maybe I'll just leave it off and then come back a few months later and repair it. But then I realized what you could do is you could actually take it off in surgery, get the knee to bend, shorten the femur down by the knee. So now you don't get the scarring of the quadriceps that people with AMC and arthrogryposis get, and the knee moves. So this is her. I just saw her in Poland when I went back there. That's her before surgery, and I just saw her now. A couple of weeks ago, I was there over July 4th because you had no conference, and that's her now with bending her knee almost 90 degrees and still having a quadricep mechanism, which I think is actually, I mean, she could not be happier, but I couldn't be happier because I do think we now may have found a way, and I try to hopefully discuss this with surgeons, and we can try this. I don't think it's trying it, I think it actually works for kids, and I think we have to rethink the way we've been treating extended knees. You know, I asked Judith Hall once, how young should I treat the extended knee because I couldn't solve it. And she said, treat it at birth, because that's the problem. These kids get really, really stiff in extension. So I think now we really may have a solution for the extended knee. And I've done this now about 8 times with really excellent results. However, again, that's not, I can hear the argument, that's not long-term. I agree, it's not, I don't have the same numbers that I have for the flex knee, but it certainly is heartening that I at least have an approach that we can take to the extended knee. So, and that was her. So I love watching this video because I never saw this before. Someone who couldn't flex their knee before, sit at 90 and then extend, and we'll get her walking now. And this was just, so I was in Poland in April, and then I was there back in July. So this was 3 months after surgery. And so I want to go back a little bit just to the flex knee one more time. And since we have some extra time, I didn't use up my time. See if it'll go back. And just talk about, so let's talk about the hip a little bit. So why do I think that the hip does not need to be brought down first? Because I think that's actually an important discussion. So, you know, the hip in AMC and in arthrogryposis, when a child is born with flexed knees, is often, most often, it's flexed and it's abducted, meaning it's splayed very widely open. And I think that the reason for that is because obviously the contracture of the knees forces the legs to be crossed in utero. And almost always, now that's not always, there's no always in this condition, but most of the time that's the position. They're out, they're abducted, they're flexed, they're up on the chest, and the knees are bent, you know, 80, 90 degrees. And then gradually the therapists try to work them down. And if they can't, then there's some thoughts that maybe we should do these osteotomies that bring the hips under the body. And I understand that desire, but I think that the real treatment is to fix the knee. So now you could bring the hips down. And if they're really bad, you slide the muscle off of the iliac crest, which is here, which is, someone taught me this today. So there's a laser pointer. And so this is where the muscles attached to the hip that are keeping it flexed and keeping it out or abducted. And what you do is you just slide the muscles off, and that allows the hip to come down. And then you actually take a piece of the iliac wing off so that the muscles don't recontract. And I've not found the hips at all, that's in the article, to recontract. They don't recontract. So you can treat the hips and the knees at the same time. I think one question you could ask me, what's the ideal age to do that? So my feeling is, and I think, you know, Fran and Mary spoke to you, our therapist spoke a couple of days ago, and if you were there, that's great. If not, I think the therapy is the most important, other than the club feet, which should be treated very early. For me, the hips and the knees are treated by our therapist at least for the first 18 months to 2 years. So the ideal age for me to treat the hips and the knees is about 18 months to 2 years of age. I love that age. If you get 2 years of age, even if it's 3. Now, have I done 13-year-olds? I have. Have I done 9-year-olds, 10-year-olds, and every age in between? I've even done a 17-year-old. So I've certainly done every age group in this. I've never, you know, I've not done a true adult, but a 17 is pretty much an adult with this contracture. And so basically, the reason why I think is, number one, I think it's safer for anesthesia. Number two, I think that a lot can be achieved by our therapist in the first 18 months to 2 years of life. And it's really quite, my approach is that they get therapy for the first 18 months, then we intervene surgically on the hips and the knees at the same time. And then then again, if the elbow needs to get done, that gets loosened up somewhere around that same time, 18 months. And then the transfers of muscles occurs at around 5 years of age on the upper extremities. So that you sort of have everything done before the child starts first grade. And that's my goal, is to be finished by first grade so the child can enter grade school without having to think about surgery in the future. And that is really my goal if I get the kids young enough to do that. And our therapists do amazing work. At times, you know, I do believe that the knees can be serially casted when they're very little to try to get extension, but we could also do serial bracing. So I just love range of motion. I think that range of motion in the hip, the knees, the elbows is really everything we want. So for instance, if you're going to loosen an elbow, don't cast it afterwards. Just keep it moving. And I think lots of articles, and hopefully I think Dr. Z agrees with that these days, to keep it moving. So, you know, I spoke for 30 minutes, which I think will leave a lot of time for questions. I don't think I need to belabor the points of this. And I think that I'm happy to answer any questions either about the paper, about data, about any questions anybody has about this technique or why we use it, or about the philosophy in general of how to treat the lower extremities in AMC. And I could speak more, you know, speak more about the bracing or when it begins, when it ends, and how we do that. So I really, again, once again, thank you, AMCSI, specifically Michelle, Joey, and Jean for tonight, and happy to answer any. And I think Joey's going to read the questions for us as you send them to him. So I will end my show, and I think I'm going to stop sharing. Is that right, Joey? Should I stop sharing?
Yes. Yep.
Okay.
Totally works. Appreciate
So
you. So yeah, we already have a significant number of questions. So excited to dive in here. Is it okay to just jump right in?
Dive right in. That's the whole purpose of me giving a lot of time for questions.
Yeah, cool. So the first question centers around your work with adults. Are there restrictions to do these procedures on adults? And if so, what should they?
So I know I don't think that adults are the limiting factor. I think my oldest child, my oldest person I've done it on, I'm trying to remember, I think is 17. I have to think back, who's an adult. So I think anybody who has closed growth plates, I consider basically an adult. So a young woman 2 years after she has the onset of menses. Do I think it's, you know, obviously if there's arthritis of the joint, if you're talking about someone who's in their 40s or 50s, I've not done that. So I can't answer the question. It would be done a little bit differently in terms of the fixation. I don't see why, if the joint is still good, if the, you know, you couldn't, but I think I'd be obviously more wary. I do still think the best age is around 2 to 3 because of the malleability of muscles and things like that. But it would have to be a reason why we would choose to do it on an older patient. It depends how old the person's talking about.
Great. The next question centers around knees in adults. Are there problems that you would anticipate encountering in that sense? Should you, you know, expand to the knees, I guess?
Yeah, so I think the opposite. So I think that, you know, cartilage dies when you don't have motion. Motion is what keeps cartilage, which is the lining of your joint, to be, you know, healthy, to allow it to be nourished by the synovial fluid. So we're not damaging the joint. If anything, we have less pressure on it because of the shortening of the femur than it would be if you use other techniques, like trying to push the knee into extension. And I really discourage the use of these anterior 8 plates on kids who have, or kids who have large deformities, because it really ruins the joint. It does. I mean, it doesn't if you have a 20 or 25 and you're 12 and they want to get a little bit further extension. I think it's a great operation. But if you're younger and have 45 degrees or 50 degrees, it doesn't work. It ruins the operation. It ruins the knee for me. It makes it very difficult. And I've certainly seen, I've done a lot of revision surgery, and that makes everything harder. So I've seen knees after external fixators. I've seen knees after soft tissue releases, and I've seen the damage to cartilage. So I think this procedure in the long run is probably very good for knees. But again, you know, I'm dealing with on average 24 months follow-up, up to 5 years follow-up. But nobody we presented on it was less than 24 months.
Okay, great. When you say shortening, do you mean that you're physically cutting bones down and making the leg shorter?
100% is what I mean. So the thigh bone is called the femur. That's your thigh bone. It's the largest bone in the body. And remember, so if you look at a height of someone, it's really just the angle, right? I mean, if you stand with an 80-degree contracture of your knee, that's your height. Your height is basically the hypotenuse of the angle made by your knee. Basically draw a line from your buttock to your heel, and that's the length of your limb. So if you think about it, if you're extending the knee, right, you're stretching out everything, right? Nerves, arteries, blood vessels, muscles, tendons. It's why the external fixator, when I used to use it, has to go very slowly, because you're stretching out tissues extremely slowly. But the problem is, arthrogryposis doesn't deal well with that, and the knee loses motion. And so what we're doing is we're acutely taking out a piece of bone up to 2 inches, usually about 1.5 inches to 2 inches, and sometimes as much as 3 in someone who has Escobar syndrome or something like that. But the muscle will keep its strength, over time because kids grow. And so that's something you have to talk about. In an adult, you couldn't take off that much. You can only take about 5 centimeters, 2 inches off. And again, 2 inches off and they won't lose strength. And so it takes time to get it back. It takes about a year to get all that strength back. But, you know, we're talking about kids who never walked. Most of these kids from those pie graphs never, ever walked. And now most of them do. I mean, some of them with walkers, depends how much underlying strength you have. And I think as we get better at making muscles and moving muscles from one part of the body to the next, which is probably the brave new world. I'd love someone to talk about that here someday, because I don't do that yet, but I would love to learn how. Because every parent volunteers to give a muscle for their child, but we haven't done that yet. But yes, the shortening is real of the bone, and that's why the bone has to heal for the first 4 weeks. That's why they're not walking for the first 4 weeks.
Sure. Can you explain more about the hip coming down? Does that happen with PT, with casts, or is there some sort of connection to the knee?
Yeah, so that's great. So no casts, no, but it does happen with physical therapy. So if you think about it, if your knee is bent 90 degrees, your hip only has one place to go. You're not going to hold your knee up if it's 90 degrees on your chest. That would be really counterproductive for anybody. So you push it to the side, which is called abduction, right? Abduction, and you flex it because it basically, you can't extend it, it won't go anywhere. So basically over time you can, so if it's less than about 30 degrees, I will not operate on the same time. If it is more than that, then I will loosen it up and then the therapist will bring it the rest of the way. We have not had any need to do a further either osteotomy of the hip in any of these patients. And now I'm approaching, I think 140 patients I've done now. I mean, 79 reported on, but about 140, and I've not had to go back on the hip. So it loosens
Great.
up, and never casting, never, God forbid, never casting. That'll just make it stiffer.
Sure, sure. Are there any long-term risks or complications from shortening? This person said maybe potential increase of fractures or potential of developing long-term arthritis.
Yeah, so no, that's a great question. We're not lengthening your joint, so arthritis is not. If anything, again, we're loosening the tension on the joint, and pressure on a joint is what causes arthritis. So arthritis is out. In terms of fracture down the road, we have a rod in the bone, and the bone heals with a huge amount of bone. I mean, these are patients who have, you know, very vibrant bone. The bone is not the problem in arthrogryposis. So, you know, basically this heals, and broken bone that heals really as strong as it was before, or even stronger. So no, I've not seen refractures of bone or weakening of bone in any way whatsoever. It sounds crazy, I know. And certainly, you know, it sounds scary, but actually it's out of all the parts of this operation, it's the easiest and makes the most sense when you think about how joints react to pressure.
Great. 2 questions here. What is the best treatment for neuropathy to eliminate the numbness and heaviness? And then what is the best treatment for hip stiffness or arthritis?
Yeah, those are great questions. So the first question, neuropathy or something like that. So so that was a big problem in the beginning. And again, if you read the paper, you'll see that we had some patients who go on to what's called, you know, Neurontin or Gabapentin after surgery from stretching, which they need if you use a fixator as well at times, because you're stretching nerves. So people with arthrogryposis should not have nerve pain per se. I think that means the nerve should be released. I mean, if it's released means decompressed. So I do a lot of spine surgery as well. And so decompressing nerves in different conditions is very common in my practice. And I must be near the perineal nerve, decompressing that one 5 times a week. So nerves can be decompressed if they're really causing a neuropathy. Now, if you have a neuropathy as a condition, that is not AMC. But that can be treated, that has to be discussed with a neurologist in a different manner. But a neuropathy from surgery or a neuropathy from treatment has to be thought about, what are we doing incorrectly? Or what are we doing to manage the patient with your medication or modalities and things like that? In terms of the second question, was how do you increase the range of motion of certain joints? So I don't know how to increase the range of motion of the ankle. I've not learned that. You know, someone teaches me that one, and I work with Dr. Dobbs now on the feet because he does most of my club feet now, and he's one of the world's expert on club feet. And I've not been able to find someone who can increase the arc of motion of an arthrogrypotic ankle, but we can make it flat on the floor. So that's important for the ankle. The hip is a really important one to keep the range of motion. So obviously keeping the hip, if you If you're going to put it back in the joint, should you put it back in? What's the range of motion? It all depends on, why it's stiff. If it's arthritic, it may need a hip replacement or a pelvic supported osteotomy, which means that you take the top of the hip and you make it the hip joint so it can move. That's a great operation for arthrogryposis. I loosen, for instance, the biggest problem in stiffness is not being able to flex. So someone can't sit. Big problem. That's a huge problem. And that I've released the back of the hip, and you free up the sciatic nerve, which lies back in there. And then you just begin range of motion right away. Once the cat's out of the bag and you have arthritis of the joint, much more difficult to think about what the options are. Hip replacement with releases, doing it together with your adult or adolescent hip replacement surgeon, which should be someone who just does that, not me. And then I release the tissues around that. So I think we'd all agree that that's very complicated, but that is how you would increase the arc of motion of the hip, which can be increased.
Thanks for that. I know you mentioned Dr. Dobbs. What do you recommend exactly for club feet that are constantly reoccurring?
Yeah, club feet's a problem, guys. I mean, there's no question. So I'm glad to have the Dobbs with us now at the Paley Institute. So basically, club feet, are treated by our therapist at first, by Dr. Dobbs early on as well, by serial casting. That's the one time we do serial casting. Well, many times I say, why don't you finish the feet before I go ahead and do the knees? And that's one of the reasons, again, we're waiting until 18 months to 2 years, because sometimes with the feet, you really do have to cross the knee with that cast. And our therapist will say, okay, but when we take off the cast, I'll see our therapist in between twice a week to maintain the range of motion of the knee, not just give up on it. So that's one thing. And then let's say the feet are recurring. So, I mean, Dr. Dobbs, when someone who just does club feet, he's better at it than I am. So that's why we've given it to him to say, yes, there are releases you can do. Now, at some age, which is we can discuss, I do give up and I say, okay, the ankle's not moving anyway. Let's just fuse the ankle in position at 90 degrees. And then the foot and then he'll do, so I just did a young girl from Ghana who had her foot back, basically her foot was backwards, 12 years old, foot was backwards, untreated. So there's no way I'm going to be able to increase the range of motion. It's backwards. So I did the ankle, I shortened the tibia to free up the soft tissues. I did a clubfoot operation. I loosened the tissues and welded the ankle at 90 degrees to the floor so she can walk. And then he did operations on the foot to allow the foot to come straight. And we did it acutely. No external fixator because it is torture. A fixator on a clubfoot is two problems. One, it is incredibly painful for the patient. Number two, it still recurs. And my partner, Dr. Paley, is probably one of the world's expert on external fixators for feet. And even he said it just comes back. So for that reason, we have gone to these acute corrections of almost everything, which means that we do it in one operation, get the foot flat to the floor. And if we can keep some motion of the joints, great in the foot, which he does. Dr. Dobbs works around the joints. And if we can't, we make sure the foot is just flat so they can wear shoes and stand up or wear a brace with no shoe. And most of these kids now, because I've actually welded their ankle, don't even need braces. Now, obviously, I wouldn't take an ankle that's recurring, that's moving 30 degrees and weld that. I would just say, I would give that, Dr. Dobbs would do releases again. And if they needed to be serial casted again and released again, you do that. And eventually, the child stops growing and you will stop having to be tortured by going in for more casting and more bracing and more casting and more bracing. I don't think Dennis Brown bars with the shoes should ever be used in arthrogryposis. We're trying to design our own braces. We use a lot of the ADMs from England for that. And they make some really small ones now. So the problem with using the shoes, the boots and bars for arthrogryposis and club feet is it really ruins the knee. It really puts too much pressure on the knee, and it's probably contraindicated. So I've convinced Dr. Dobbs to stop using it on the AMC patients, on the arthrogrypotic patients, and he stopped. And using a lot of ADMs and using other kinds of bracing that we can really be creative with to keep the foot supple. And he's showing some good results. We'll try to publish on that too in the next couple of years to see if the fact that he's taken over my practice for that makes a difference. But I do think each child, if they have no motion anyway, if there is no motion of the ankle, then let's just give up on trying to keep on recasting it and recasting it and recasting it. I don't particularly like osteotomies of the tibia rotationally. inward or outward for club feet. I just don't think it holds or helps us anyway. And again, you're recasting and recasting and to come back and recasting. And how many times can you remove the child from school to recast them? Every year for 3 weeks, every year for 6 weeks. So what's it going to be? And that's why I think that we need to think about the child's life also at some point in this story and say, okay, you know, we're failing on the feet. And we, all of us, every surgeon who's ever treated arthrogryposis has failed with feet. And every child out there and family out there knows that we have failed with feet. So we are finding ways not to fail with feet and thinking about the child's overall care as well in that regard.
Sure. Appreciate all that. So this next question is around a procedure. I'm not sure which one, but hopefully we can figure it out. Does this procedure involve any work on the leg muscles too? I was told anytime you cut to gain, you lose something. Is there any reduction in muscle strength in the legs when you get a gain in range of motion in the knee?
Yes, you have to think about that. I mean, so the question is what muscles do they have before and what muscles they have after? So you're not cutting all the muscles, that's for sure. Even the hamstrings could be reattached. You're loosening up the fascia and the capsules and things like that. Sometimes you're loosening up the ligament in the knee. But you're very often leaving muscle. So the quadricep, because you're shortening the muscle, if it did, usually it has if a person has a 90-degree contracture, they don't usually have a very strong quadricep. But they will be weak for a while and then it gets strong again. The hamstrings. So the hamstrings reattach quite well no matter what you do. So it's not like cerebral palsy arthrogryposis. It doesn't have that weakening impact when you loosen up muscles. You try to keep them functioning, and that has not been weakening the child is not the overall problem. That is more of a problem around the hip than it is around the knee, I think. You don't want to loosen up too many muscles around the hip. That's why we slide them instead of cutting them. So we don't cut the muscles, we just change where they originate. And that's why I don't think we have that problem as much as it would if you just cut the psoas tendon, cut the adductor, cut the abductors, cut the flexors, and then I think you have some weakness. So it's a really good question. I think, you know, it's certainly something we can look at down the road, but certainly the function level is just, the change in function level is amazing. So obviously they show muscles that I don't understand sometimes. I don't think they have a quadricep, and if it's even what's called 2/5 before surgery, which means that they can't even go against gravity. Sometimes they could just walk afterwards, even without bracing. I have a young girl from Minneapolis, and literally I think I saw her this week. She can walk without her braces, but she has very little quadricep. So it's just because she has enough to just do it. And she's, you know, she inspires me how she does it, but it's incredible.
Awesome. Another question from a parent. Can you speak more about the why behind not casting above the knee? She asked because her daughter suffered femur and tibia fractures after spica casting with no apparent cause. She's always wondered if it was because her knees were being stuck in one position for so long or not. And then another question around always recasting, and when do you recommend surgeries that are more invasive than tenotomies? So a couple of questions there.
Yes, I'm not sure what the question is exactly, but I'll try. So first casting, so above the knee. So we do in the real babies for club feet, yes, sometimes we go above the knee, but again, we take it off 2 to 3 times a week for them to get therapy to maintain the motion. Casting is, so this is really, you know, I'm speaking now from my philosophy, and I, you know, I think I have enough experience to say this stuff. So casting in arthrogryposis is horrible because your joints are stiff. Why would you want to make them stiffer? When you cast, bones get weaker. When you immobilize and you keep people off their legs and you put frames, they make the bones weaker because bone needs pressure to build bone. If it's in a cast, it resorbs the bone. If you're on the space shuttle, it resorbs the bone. If you are in a fixator, it resorbs the bone. So you basically need to put weight on bone for it to be strong enough. And so that's why these kids are walking 4 weeks after this surgery. And there's no casting. And also, it's a stiff jointed disease. Why do you want to make it stiffer? Just to make it straighter is not always better for the patient. I mean, I don't know if I were a patient as an adult, I don't know if I want bent knees or total. If someone said to me, do you want 90 degrees knees bent or 0 degrees straight? I don't know the answer to that. I think I'd probably prefer to be, you know, bent. I want to be able to sit in a chair. So that's why I think motion is is the solution here. And I'm preaching I'm preaching not to the choir in this case, because this has been a hard argument to make for this condition. But we've learned it for so many joints, the elbow. And yes, your child broke their femur, mainly because it's disused. It's called disuse osteopenia. And they break over again. And you take a fixator off and they break. And I wrote a paper in 2007 on using fixators to straighten knees. So I've been there, I've done all this, I've casted, I've been through the whole thing. I've gone through this whole, and I hope somebody after me tells me where I could have improved on this, But I'm just trying to say that, yes, that's why I hate casting and arthrogryposis, and why if I allow, so for instance, when Dr. Dobbs came down to, to West Palm Beach from WashU, I said, no, you're not just going to cast the cases every week. We're going to have them twice a week. We're going to have therapy moving their knees in between the casts. So yeah, so he's on board. We're actually, we've created great synergy now because he has experience with club feet that I haven't seen. I have experience with knees that he hasn't seen. So it's this great synergy that we can figure out how to do this where kids don't lose it. But, but a lot of times he says, okay, I'll only short leg cast in an older child. Child's 3 years old, I'm not going to put a cast across their knee again because I'm not going to lose the motion we've had or all the gains they've had just to get the club foot corrected. We'll figure out a different way. And he has. So yeah, for an infant, it's different. But for a 3-year-old who I've done the knees on, I don't want anybody to cast those knees ever. So if they broke their femur, I'd put a rod in the femur and keep it moving. I would not put you to spica cast and tell you to stay in the spica cast for 8 weeks because you'll lose everything. So it has to be different. It may sound counterintuitive, but in my opinion, it's true.
Awesome, thanks for all of that. I think this is going back to the main procedure discussed throughout the presentation, but what would make an AMCer not a good candidate for a procedure that you lead?
So that's a great question. So I think that is the same issue with anybody or any surgeon who's going to straighten a knee. And so, and I think I've seen children who saw their physician surgeons and said, don't do it because the child's never going to walk. And then they walk. Now, underlying muscle strength is really the key that all of us cannot create yet, right? So like the child I showed the video initially, he had great core strength, right? He was walking on his knees before I treated him, right? So that's a home run, guys. I mean, I'm showing you a home run because not every kid can do that who has AMC. Not every kid has that much strength to be able to walk on their knees before surgery. If they do, then I'd say, oh my God, it's a great candidate. But and a good candidate would be, well, they still have some strength, or they have good, where they can roll, like that little baby could roll when I showed you, and now she's walking on a treadmill. But there are some kids with AMC who have no strength at all, right? There's no muscles at all. And I think those, you have to question whether anybody should do anything to straighten any joint, or should we just make them be able to sit comfortably in a chair? And that's when we have to weigh out those issues. And there's certainly some kids who I've told that to. There are some people on ventilators who have no strength at all whatsoever. So I think we need to respect the fact that I'm not going to say all, but I don't give up easily either. I think that you don't have to have great strength, but you have to have, there should be some strength there before we start doing this. But there are many reasons, but you also want them to sit comfortably in a chair, or be able to stand up at home when they're children. There's different reasons why you think you're going to do it. Even if the child's going to use, or an adult's going to use a wheelchair for most of the time, maybe they'll be able to walk around the house a lot. So we do have to have reasonable goals. And I think that each patient should be treated individually by all of us and said, is it possible? But there's a little boy from Vietnam who I treated who walks beautifully now. I was told to never walk. So, and he walks beautifully. So I think that I wouldn't give up easily either. Our therapists are pretty aggressive in terms of not giving up at all. I've treated a kid now, I think from Texas, who basically I thought had very little strength and rang the bell yesterday. If he's listening on, he knows who he is. Adorable little kid who never smiled at me till he rang the bell. And basically he's walking, and he's walking with a walker, but he's walking and smiling with his knees bent on a table. So, and the amazing thing is you say, well, is it really painful? That should be a question. And, the kids don't like me when they first come in and see me the first visit. They don't like me the first surgery afterwards, but all of a sudden they see, even when I've done one side and not the other, I have not had a child say, I don't want the other side done. Even a 3-year-old. yes, I want my knee to look like that. I want to look like my brother. I want to look like my sister. I want to look like my mother, my father. I want to look like and it's actually unbelievable. And how close I am with all these kids, even after I've certainly caused them some pain.
Sure. Well, we have a comment from an attendee on one of your previous statements around casting. This says, please tell the doctor that I agree on the casts so young. I had surgery 3 times on my feet. I'm now at age 54, and my feet have been fused for over 30 years. So just wanted to share that experience.
So I think that's the case how I see always. I mean, so why torture you and not just fuse your feet? They're going to be fused. I mean, but that's not don't say every again, because some people with arthrogryposis do have ankle motion. I mean, this condition is really variable. Everybody on this group, sure. I mean, I guess there's like 50 people listening, on Zoom. You all know how variable this is. So I'm not preaching to anybody who doesn't know that. So that person I agree, that's not everybody.
Awesome. We have maybe 2 to 3 more minutes. A couple of quick questions. Can we get copies or a list of papers from this talk?
Absolutely. I mean, the talk is available to you, and the paper is on the website, and it's an open access journal, so you all can download the journal, and you can email me if you have questions. It's on my website. You can email me questions.
Great. One question about cost. Our son is very young, so we're very new to the world of AMC. What would a surgery like this cost? In trying to figure out, the cost they may anticipate these.
Yeah, this is a painful part. This is painful because obviously some of the people talking today, not today, Dr. Frumberg, I believe, is at Yale, but Dr. Heyer is at a shrine, Dr. Van Bos is at a shrine, Dr. Nichols is not. So yes, I mean, we take all insurances, all commercial insurance. It'll cost you nothing other than your deductible. So, and we try to do everything we can not to make that. Obviously the shrines don't cost anything. And I think that's really an attractive, part of going to a shrine. Sometimes the waiting list is longer and maybe we don't treat things exactly the same. So the cost to you, I mean, then we have a quantum house for us, at least. I mean, you're asking us specifically, we have a house on campus for patients. And if you give enough time, you can get in there, and that's very inexpensive. They give meals and you meet other kids with AMC. And it's like a Ronald McDonald house we have most of our children are there. And it's an amazing place. I mean, if I go visit, I can't even have a meal. I mean, it's just geared for kids and geared for families. There's families have a room to go to do work. I mean, it's really an amazing, it's called the Quantum House. And I can't say enough. Every year I give to them. They're just an amazing group of people who do this as volunteers. And it's just unbelievable. And in terms of the surgeries, yes, I mean, if you have commercial insurance, we take personally all commercial insurances. Obviously, we can't take state insurance because they won't allow us to. I would if they could, but we can't because those are all state-run insurances. Sometimes we get approval from international companies, but yeah, I mean, when it comes from international, it's difficult. I mean, I go to Poland, so I treat a lot of patients from Eastern Europe, and patients from Poland come to us. And the communities collect money. It's unbelievable. I mean, the towns collect money to do this. And but you're right. I mean, I wish it didn't cost. And that's specifically depending on the care. But I mean, to pay out of pocket in America for, private care is unaffordable. It's, almost unaffordable. Sure. But we try to make it affordable, but you'd have to have a very big bake sale to make it happen.
Sure. This has been wonderful. So appreciative of you. Thank you so much, Dr. Feldman. This has been such a great call.
Well, I'd love to see. It's so hard without people looking at people. But Joey, thanks for staying on and looking at me for an hour.
Anytime. Hey, Gene.
Thanks, everybody. Thank you all for listening to me. I appreciate it. And Gene, you're still muted for some reason.
That's because I haven't said anything yet, but with that, Joey, I think we're going to take a brief break, but I think you were just about to say thank you to Dr. Feldman. So I want to be sure to let you do that before I put us on our break screen.
Yeah, absolutely. I mean, truly, Dr. Feldman, it's been such a pleasure to get to know your perspective more. I've wanted to attend all of your sessions in years past, and it's super exciting to actually be able to have this conversation with you. So thank you for sharing all that you did tonight. And I'm hopeful that, everyone in this chat can continue to stay in touch and abreast of all the great things that you're doing at the Paley Institute.
Well, thanks, Joey. Thanks, Michelle. And thanks, Gene, and all of you at AMCSI. Really appreciate it. Hope to see you next year somewhere in the lower 48.
somewhere. Thanks. Awesome, Gene. Oh, and now we're doing a break.
That is
Great.
correct. We're going to take a very brief 5-minute break because we do recognize we may have some families out there with little ones or people who need to step away, get a beverage, just use the facilities. So we'll take a quick 5-minute break. And while that's taking place, as that break timer is running down, our second speaker is with us. So when that timer gets around 1 minute, I'll ask Dr. Frumberg to, oh, there he is. Look at that on camera. Fantastic. So again, we'll take a quick break and we'll get started with our second speaker here in just a moment. So thanks, everybody. We'll get started here very, very soon. All right, we are coming very near to the end of our break here. Oh, look at me. I just jumped us forward way too quickly. I don't want to steal any of those precious few seconds. So as you're getting back to your seat or your couch or wherever you're viewing, I'll just remind everybody that we are going to resume with our live broadcast here in just a few moments. So now is the time to settle in and get situated. So I can see our fabulous facilitator, Joey, is back on the line, as is our next speaker, Dr. David Frumberg. So this is excellent. And I'm going to let that timer count down, because I feel like some of us need an extra 10 seconds to stretch or get ready for our next presentation. All right.
Oh gosh, it's like waking up in the morning. Careful. Thank you so much, Jean. I am so excited to introduce the next presenter, everyone. Tonight, we are extremely lucky to have Dr. David Frumberg presenting to us tonight on AMC Adults, Hips and Knees Analysis. A little quick background. Dr. Frumberg is an assistant professor at Yale School of Medicine, where he directs the cerebral palsy program and the Yale Limb Restoration and Lengthening program. He enjoys collaborating with other medical professionals to maximize the functioning and comfort of patients of all ages. He's devoted to providing his patients with innovative and compassionate care throughout the lifespan, especially those with AMC. Thank you so much for being here tonight. I think we have tons of adults on the line that are thrilled for this presentation and ready to absolutely hear and absorb everything that you're about to tell us.
Well, that is a great intro, man. I'm like so bashful usually, but that was awesome. Thanks. Thanks everyone for having me. This has been a really great week of evening talks. And I wish all conferences function this way, where we could all kind of like hang out at night. This would be a lot better in person, but I guess if we got to do it, this is a good way to do it. So I'm really thrilled to be here and participating, and hopefully I can maybe enlighten some people, because I do see quite a few adults with arthrogryposis, and the majority of them actually come either from members of this support organization or through the words that get put out by members of this organization. So I'm really honored to talk here. Before we begin, there's going to be an opportunity for polling in just a minute. So if you have a phone or something, we have a couple of questions we'll ask. I have no disclosures that are applicable to this talk. Before I start, and this kind of is a theme that you guys know, this was sent to me by a mother of one of my patients. That she found it online. And it basically shows one patient in the middle, initial G, and this is their entire support organization, all the people that they had to interact with in order to get through their childhood. So, one child with a family surrounding them, and then all the million of other people that they have to be involved with. And, parents of some of the kids with arthrogryposis really this resonates with you. I mean, this child G has cerebral palsy, but there are some parallels with the requirements for IEPs and things like that for kids, that then when you graduate into adulthood, good luck surrounding your family with a couple of boxes, right? So the first question I have is, what does it look like when we go into adulthood? It's for what's so-called childhood onset disorders or childhood onset differences. There's certainly not much in the adult community, right? So if you look at this paper from 2019, and some of the names in some of these papers, you'll notice, you'll know them. It's the same few people who do the research, which is great. But this is just an overview of what rehab looks like throughout the lifespan. And in the section on adults, saying that adults are doing life. The whole childhood is getting ready for adulthood. So it's focusing on independence, and maintaining your health. But at the same time, all the rehab services go away. The goals that are being focused on are vocation, leisure, education. So that's pretty much it. That's all, that's all anyone could say. No one can say like, oh, what happens when, I have a child and I need to rehab after that. So there are a lot of unanswered questions. So the question of what happens in adulthood is going to be key. Before I move on any further, there's just two poll questions that are going to help me kind of shape my understanding of the audience here. So can we pop up the first two, or the only two? So the first question is, how many surgeries have you had specifically on your legs? So this includes your hip, your knees, your thighs, your legs, your ankles, your feet. You could even include your toes if you had something done there. So that's the first question. And then the second question is going to be, how many days out of the week do you experience pain? And your options are 0, 1 to 2, 3 to 5, or 6 to 7. If you could submit those, we'll give you another couple of seconds here.
Okay, we're getting some great turnout, and I'll just remind everybody, this will really help our presenter in his talk. So if you have had surgeries, and again, you have pain, please be sure to submit your answers. Your answers are anonymous, so we would appreciate you participating in that poll. And as I'm starting to see the responses slow down a little bit here, notice the high pitch in my voice. I'm gonna close it now.
Right about now.
Ending it. All righty.
All right.
So let's take a look at those results.
All right. So, this is the theme, and this is great. Thank you everyone for participating, but this is, remember these numbers. So, somewhere 4 to 9 surgeries, about half of you, and 6 to 7 days out of the week with pain. And, I should have said that this is really for adults, but that's the case. So that's a theme that we will see. So what happens in adulthood? That's really the question, right? That's what you're all here to know. So basically my talk is going to go like this. How are adults doing? Because you can't start understanding how to change things unless you know what you got. And then we'll just talk a bit about hip and knee. Now, this is not a contracture talk. So contractures are really, Dr. Feldman is like a contracture expert of many other things as well. But you guys have had a lot of contracture talks. I do see adults with arthrogryposis that have contractures that have persisted. However, this is not going to be a talk about that. This is going to be more like adult type things that I see in the office. Okay. So the first question, how are adults doing? There's a study this is all pretty recent, a lot of these studies, which is great. It means that research is picking up. So in 2017, you guys will recognize some of the names on this. So, Judy Hall, everyone knows that name. So long-term functional mobility outcomes for individuals, AMC. So in the long term. And what you're looking here on the bottom in the gray bars, so higher is better. The gray bars are the US general population. The black bars are all the individuals with arthrogryposis that were participating in the study. And I really want you to see that on a lot of these, the AMC population does really well. So physical limitations perceive less limitation than the US population. Emotional limitations, much less. Vitality, a little bit less. Physical function, a little bit less in those scores. However, mental health, social function, body pain, general health, just much better than the general population. I think if you've met adults with AMC, I think that kind of goes along with my experience. Just really happy, healthy people. However, there are some physical functions that we know are limitations, but they do not perceive them as limitation. And I think that's what's key. If you look a little deeper in the data, this is where it kind of gets a little more nitty gritty, but 90% have pain. And that's what we saw when we polled our audience today. I'm sorry, of the people who have, 90% of them have joint pain, 35% have spine pain, and 15% have jaw pain. So it is common themes that we see. And then if you look at just some of the more home and community ambulation measures, there's a lot of independent walking and really not as much wheelchair ambulation than maybe you would have expected. So the far majority of the population is independently ambulatory. And I think that speaks, volumes to what we're looking for. So very good. Now, quality of life, satisfaction with life, functional mobility in young adults after leaving pediatric care. This is a study from 2019, 23 young adults. Physical function was lower, but the rest of it was definitely equal to the general population. And the ones who were unsatisfied had higher anxiety, depression, pain, fatigue. So you could see that the most people are satisfied with their current functioning or extremely satisfied. The ones who are dissatisfied are ones that maybe we have to focus on. Why is that? Because with a higher risk of anxiety, depression, pain, and fatigue, is that something we can change going forward? More research is needed. And then this is always important to understand qualitatively what are the concerns. So this is just a laundry list of all the different concerns that were reported during the study. But me as a practitioner trying to understand adults, it's helpful for me to understand maybe some of the issues that I maybe take for granted. So, obviously finding reliable caregivers, that's an adult problem that parents never want for their kids. So that's a big focus in the teenage years and going forward. So making sure there's a good support system, but there's many other things, even simple things like negotiating curbs, tight spaces. I'm sure there are members in this group who can beat me to a soapbox about the ADA, but we'll leave it at that. I want to be asked back next year. So, all right. So disability in adults with AMC is severe, partly invisible, and varies by genotype. This was an intriguing study from 2018. I believe it was out of France. So they took 43 people, brought them in for a few days, and had just many different types of professionals evaluate them comprehensively. And what they basically found was that muscle weakness and joint stiffness was pervasive. Gait disorders were due to a skeletal cause and not due to like a neurologic or functional decline or pain or things like that. So the underpinnings of gait problems in adulthood were due to skeletal disorder and really only found in the amyoplasia subtype. Chewing, swallowing, speech orders were also common, but again, 91% reporting pain. So pain is definitely a predominant feature. This is an interesting type of graph, but basically the further out you are, the more independent you are, and the more toward the center you are, the less independent for each of these functions. And you can see amyoplasia, which is the majority of AMC, just function on a slightly less independent level. And then, again, there are some limitations. I'm not going to get too far into this, but the upper and lower extremities both equally affected. This is a really good graph, a little bit busy, but it's really about pain. And you can see people with AMC, 90% of them do report pain. So 39 out of 43. And then where it is, mainly in the lower limbs and the trunk is by far, just by being a North American, you're at risk for back pain. So it is pervasive in this group. And then here's the psychological problems, which I think are probably the things that people don't look at enough. 43% reporting anxiety. Interestingly, only 4% reporting depression in this study. Fatigue, 34%. That's a common thing, kind of goes hand in hand with pain interference. And then other things, sexual life, self-esteem, solitude, I would say 0.25% with sexual dysfunction and 14 to 17% with self-esteem and depression type concerns or loneliness concerns. That is something that we cannot poo-poo. But if you see here, difficulty in planning parenthood, very low percent. And I think that speaks to the awesomeness of the population. So, all right, can anything be done? Well, here's my slide about that. Everyone who's ever participated in anything with AMC has said we need more research into adults. Hopefully going forward, that's something that people like me and others can help tackle. So I don't have any answers to what we can do, but we can certainly start. Here's one study that could help, just starting to understand everything. It's a pretty nifty study. They took 83 people with AMC. They looked at their number of surgeries and, the average number of surgeries was almost 10. So that's kind of on par with what our group here. Most people have foot surgery, half had knee surgery, and some had hip surgery. Basically, they looked at the physical capacity, and how they define that is a little bit interesting. But what they found was that if you had knee and shoulder surgery, it seemed to have a negative correlation with your ultimate physical capacity, whereas elbow surgery had a positive correlation. They kind of felt that if you improve your elbow function, like Dr. Zlotlo has taught us, then it improves your independence. So maybe your physical capacity is better. So, we're just kind of starting to understand what all this means. That's just a very brief overview of where we are. So I think the take-home message for that, in my mind, is that adults with AMC are doing great, but they do have, a lot of them have pain, 90%. And, concerns like fatigue and psychosocial factors do persist. And so like an orthopedist, I got to work with other people to figure that one out. So anyone in the audience wants to help, let's do it. All right, let's talk a little bit about hip. Again, this is not going to be a contracture or dislocation type talk. It's going to be more of an adult talk, just to tell you things that are available, things that I see very commonly when I see an adult with AMC. So it's not like just because you have AMC, you're going to have this. It's just some of the complaints I get revolve around these things. And again, very little research into this stuff. So take it all for what it's worth. So just like brief anatomy here. I know this is very simple, but your hip is the femur bone and the pelvis. It's supposed to be covered with cartilage. The socket's supposed to be deep, and the joint capsule is supposed to be nice and tight, but loose enough that you can move the hip. If you have multiple surgeries, it alters every single one of those things I said. So it's very rare for me to see, an adult with a perfectly round femoral head and a perfectly round socket, and obviously, perfect motion. There actually are a lot of people I've seen with distal arthrogryposis that still have hip problems. Go figure. So I don't have any answers for that. But when people come in with hip pain, often there's an assumption that something in their childhood, some surgery they had in childhood has caused it, that many years later. And to some degree that might be true. Hip surgeon, Dr. Van Bossen likes to tell us that there's really no good evidence that putting dislocated hips in arthrogryposis causes stiffness. In fact, I believe he showed the opposite, that it does not cause stiffness. And so we still believe that trying to get a hip to be in the socket is better than having a hip out of the socket, because the adults I see with hips out of the socket actually don't function very well, but that's purely anecdotal. I don't have like a good research to show that, like I said before. The most common hip pain I see is outside the hip, and it's not caused by the inside of the hip. It's caused by the back. You can see all these yellow things. I was going to put a picture from the bodies exhibit, and then Michelle was like, hey, there's going to be kids there. And I thought that might be a little gross. So I just found a photo online, but all these yellow things are nerves. So you can see that this is the sciatic nerve. These are some nerves that come around your hip, and they all come from the back, and they have to escape the canal of the spine through these little holes. And if there's something that's causing those holes to be tighter, or if the back is stiff or has arthritis, then you can get referred pain down toward the hip and report hip pain, but actually have back pain. That's very commonly seen. The treatment of back pain, I have a lot of really good partners who take care of that. It's pretty standard, but it does not mean that you had scoliosis or something like that. It's usually adult type arthritis and back stiffness. And there's a whole bunch of treatments for that that are not surgical. But so going back to the hip, so like my big theory here is that I talk about all the time. My residents think it's gold, so they said I had to call it Frumberg's theory, is that, so there's this concept of joint reactive force. So your hip, your femur, is being driven into the socket by the pull of muscles that span the hip. So even when you're just sitting down or standing up, your quads, your glutes, your hamstrings, all those muscles around your hip are exerting force on the hip and pulling it in toward the socket. So the thing in arthrogryposis is that some people don't have the strong enough hip spanning muscles. So you think like, maybe that's not happening. But my thought is that the tightness plus the intrinsic joint reactive force that you have, those combined, plus maybe any surgeries you had before, will accelerate a process of increased forces across the hip. Again, no research done in this. It's just my theory, because I see a ton of arthritis in the hip in the adult population with AMC. Arthritis, basically, there's many different types. We most frequently, when we say arthritis, we're talking about osteoarthritis. And that's the type where you have degeneration of the cartilage in the hip, which leads to a whole cascade of events and inflammation that breaks down the cartilage and causes bone-on-bone arthritis. In our center, so I'll get back to it in a second. The most common things I see are, first of all, referred pain. The second thing I see a lot is arthritis, like osteoarthritis. And the other thing that I see a lot is just bursitis, inflammation of these little sacs of fluid. So this is looking at a hip from the back. Or actually from the front. And what you can see here, the IT band There's a couple of muscles here, but basically you have all these different potential sacs of fluid that can get inflamed. And if somebody, for example, has extremely tight muscles or a really tight IT band, or has some other reason, maybe they're using like HK-AFOs and they rub in a certain way, you can get inflammation in these places that responds pretty well to injection or anti-inflammatory approaches. When I say injection, I'm talking about like steroids and things like that that could help decrease inflammation. So that's also very commonly seen. I have a really good team here. You know, a lot of people don't know still what arthrogryposis is, but luckily I have some partners who have really embraced the population. Mike Leslie and Dan Wisnia are my hip replacement doctors that are really great. Mike Leslie recently did an adult with AMC who did really well. Darren Arsoy does a lot of the other like intra-articular stuff, hip scopes and stuff like that. And Jen Hankinson is a physiatrist who really focuses, she sees kids to adults. So it's really nice to have someone who can take care of adults, help with the transition, the rehab. So here's a good case example. This is a 42-year-old mother of 4. She is awesome. And if you look carefully, you can see that she has a lot of hardware. So this ankle is fused, but this ankle is also fused. There's been a whole lot of stuff done here. And you can see her hips are in, but if you look at her right hip, so this is as if she's facing you. So the right hip is going to be on the left side of your screen. So it's this hip here. You can see that it's just not quite round. It's a little bit misshapen, and it is extremely painful. It used to function as a hinge, not really a ball and socket where it can move all around, just a hinge because it was misshapen. But ultimately, this one goes on to need some treatment. And in this case, what was done for her was something called a total hip arthroplasty. So I don't do hip replacements, but I kind of help the patients through the process. And my partner did this one. And so you can see the cup here, and I've broken down what the implants look like. There are many different types of implants, and each one is different for every individual hip joint. But you can see this is the stem that goes in the femur. It's usually covered with like a little ceramic ball. And then there's a little plastic piece or a ceramic piece that goes over that, which gets impacted into another metal cup. You can put some screws in if you need it. But this one was done. It went very well, and her pain had resolved. So she got back to her life. You know, she's 42, so she's much younger than the typical population. You know, when you think of people getting hip replacements, you might be thinking more of the geriatric population. But in AMC, we do see very young people requiring this type of treatment. That's what I'm going to say about the hip, because I know I'm probably going to generate some questions, but I'm going to move on to the knee, which is extremely challenging. The hip is, you know, like at the end of the day, replacing a hip, there are many different solutions to many different complicated problems. The arthrogryposis knee is something that is just so hard to grasp my head around. The knee is complicated. Here's a couple of different pictures just to help orient you with anatomy, but just like the hip, you have 2 bones. In this case, you have actually 3 because you have the little patella there too, your kneecap. But the femur and the tibia are covered with cartilage. And then that cartilage, again, can be subject to arthritis when things are abnormal. If you look at the picture on the left, this little soft tissue thing in here is called the meniscus. These little white things here are called ligaments, like this is your ACL and your PCL, which are things that you hear about. And so there are a lot of different things in the knee that could, for more or less, go wrong, be stiff, be out of place, be pain generators, cause a lot of disability. These are, again, you know, some teammates I have here, which make it a really cool place to treat adults with AMC. So again, Dan Wisnia, he's the hip and knee replacement guy, but also really into like 3-dimensional patient-specific things, and I'll show you what he does. And then John Fulkerson is one of the guys who's been known like across the globe for kneecap disorders. So the gliding of the kneecap, which I'm sure a lot of people in the audience have had operated on before. And so, you know, when I come to each of these guys with someone with AMC and tell them that we have a problem to tackle, they're very willing to take on kind of out of the box problems and come up with maybe in or out of the box solutions to take care of them. I'll show you some examples. So, just like the hip, if your knee is not functioning properly, maybe you had some surgery, maybe it's over tight, or maybe you just wore it out, you end up with bone-on-bone arthritis. And this is that osteoarthritis we're talking about. And you can see that when we say bone-on-bone, we mean there's no cartilage capping the ends of it. And so arthritis is very commonly treated with replacement. So I'm going to show you an example. This is a 61-year-old teacher. You can see here that on her knee, she has much less space between her femur and her tibia because the cartilage that's usually padding it there is missing. And so that is osteoarthritis. And so when we look at her CAT scan, we can see that her body has laid down all these extra bone spurs and it doesn't have quite the same range of motion it should. And her alignment is off. So using her CAT scan, because usually what happens in arthrogryposis is maybe you've had surgery before, or maybe there's some other deformity that's been treated or has developed, or we've just accepted when you were a kid, but when you're an adult, if we try to put like a metal and plastic joint in and the alignment is not perfect, then that could lead to that joint wearing out over time. So one of the things we try to do is get perfect alignment of those components. This way there's less of a risk of them wearing out over time. So like these total joint replacements are kind of like cars. If you take it out and go off-roading and stuff like that, it'll probably break down. Whereas if you treat it nicely and it's appropriately serviced, then it'll last much longer. So this is a robotic assisted knee replacement, which my partner Dan Wisney likes to do. So there's a robot here. And this is not a human, this is like a model, but basically based on the patient's anatomy that, preoperatively, you can use this device to assist making perfect bone cuts and putting implants in perfectly to that specific patient. So we like this for AMC because it's really not a one size fits all kind of situation. And this is what it ends up looking like. And you can see this is just one example of a knee replacement. There are many different types, but this one looks pretty good. Now the anterior knee, so the patella, how it glides over the thigh bone, the femur, is really, really difficult problem to treat. It relies on bony anatomy. It relies on the muscles. There are many of them. It also relies on the joint moving appropriately. And there are a lot of different factors and a lot of ligaments that interplay. So this again is not something that we advocate like a typical approach for. So what you can see here is that like the distance here of the quad tendon and the tension of the muscles as they pull on the kneecap, it's a little complicated, but we want those things to be perfect for people with AMC because they really do have unstable kneecaps. And then also maybe part of the quad, one thing we see a lot is like half the quad is really strong and half the quad doesn't exist. Or like if they're in your hamstrings, you have many different muscles that kind of come together. We'll see like one or two of them look great. And then when you do a surgical dissection, you just can't even find the other one. So it's a very interesting anatomical consideration. Here's a really good example of a 23-year-old girl or woman, young lady, I should say, who's a college student. And this is just a cross section of her CAT scan, looking at her knee joint. So here you can see her kneecap is not sitting in the center of the groove on either side. She's had surgery before. She has AMC. And what this leads to is like here you got bone-on-bone arthritis. And also she can't really bend her knee because it hurts when she does it. So that's what I'm just trying to show you there. So the patella is not sitting in the groove because the ligaments are unstable, the muscles aren't pulling appropriately, and the anatomy is not correct. Here's a 51-year-old woman who is active in yoga, and she's had a lot of surgery as well. And what you can see here is the same thing. She has a big cartilage lesion underneath the kneecap, and her kneecap does not track appropriately. So I actually operated on this lady. She's easily one of the best patients I ever had, but here's a video. She's asleep on the operating room table, but if you watch her kneecap, which is right here, I should have marked it now that I think about it. Just watch how it moves. So as I bend it, you see that little like jump there? That's it trying to find its way into the groove. So watch it again. You see how it wiggles out to the side? So she's asleep. She has no muscle tone. I'm going to play it again for you. You see how the kneecap moves side to side? That's abnormal. It should just go straight up and down with maybe a little bit of deflection, but hers deflects quite a bit. So that is a problem when you have AMC, we believe, because your quads may be weak and they can't function efficiently because they're not pulling in the right direction. So this is, again, all theory, but it matches her symptoms. Let me try to advance my slide. Sorry. We like to do a lot of 3D printing and 3D modeling to try to figure out what is the most appropriate thing to do. So this is the kneecap, and you can clearly see that she has a groove. When she was born and was developing, she had a groove, and then at some point her kneecap started exiting over there. So there's like the second groove over here. And this is how her patella actually tracks as she flexes her knee. We call that a J sign, and you can see why. It looks like a J. These are contact pressures that we use just for some modeling. I won't get into it, but you could clearly see the kneecap is not sitting where it's supposed to sit. It's really out to the side. And here's Dr. Fulkerson, the master, and me kind of having fun in the operating room with a different surgery. But this is an example of things that we do. So, you know, you can move the insertion site over. That's actually a osteotomy that Dr. Fulkerson described, but I don't think he was thinking that I was going to drag him to this adult AMC conundrum. And then this is a ligament reconstruction that we typically do to prevent the kneecap from moving sideways. So a lot of other things we could do, but this is a really nice combination of things we could do. So he brings his patellofemoral expertise, and I bring my arthrogryposis supposed expertise, and we try to get the best possible results we can go. All right, so where do we go from here? Just in summary, you just have to know how I see this. And I'm sorry. So we know that special challenges do exist for adults with AMC, and I could give you like a 30-hour talk and we wouldn't cover it all. And we know that we have to do our best for the entire lifespan, no question. But we don't have enough research into this. And I think a lot of that starts with the assumption that this is a pediatric problem, and we just haven't followed things out far enough. We do have options that exist for orthopedic treatment, but one thing I failed to say at the beginning of this talk and throughout it is that of all the patients that I see virtually or in person with arthrogryposis that are over the age of 18, I probably do surgery on less than 2% of them. So, you know, it's not common that you need surgery. I'll give you a great example. One of the first people I saw who, I don't remember if Ani or somebody sent to me, but she was a woman who was a new grandma, and she was in the office. She had amyoplasia, untreated elbows and hands, but functioned very well. And she had a newborn granddaughter who she brought with her, and she was complaining of ankle pain. I got x-rays. She has ankle arthritis. I walk into the room to try to explain all the ankle arthritis problems because she had clubfoot surgery, all this stuff. She's holding her newborn grandchild in one leg, like her legs are crossed. She has the newborn grandchild on her knee, in her leg, and she's holding the bottle at the baby's mouth in her foot. And I said, oh my goodness, like I can't possibly do anything. So I gave her an injection, but she needed a fusion. But if I did that, she wouldn't be able to feed her grandchild. So, you know, a lot of the adult treatments that you would classically need in the orthopedic world would take away a lot of the mechanisms that adults with AMC have relied on their whole life. So it's very interesting, and I very rarely offer orthopedic treatment. And most of the time that I actually do tell somebody they need a surgery, if it's pretty straightforward, I usually tell them to get it closer to home where their support system is, if they can find an orthopedist there. It's kind of rare maybe to find an orthopedist, I'm told, that will listen, I guess, but I have given some pointers to some orthopedists, but you know, in general, I think it's just it's not that you need surgery when you're an adult. I don't offer very much, but some people do have problems that would benefit. Accessible workforce goes on to kind of what I was just saying, just orthopedists and physiatrists and pain doctors and primary care doctors and people that just understand what arthrogryposis is and are accessible and are motivated to take care of the population. I could talk for hours. I'm going to stop right there.
Thank you so much. We have a lot of questions that I'm sure you're excited to get it into. Is it okay to jump right in?
Let's do it.
Okay. I think the first thing that has been obvious throughout this entire chat is you have a lot of fans out there that want to become a patient of yours. So the first questions all center around that. Is your practice at Yale? Are you located at other facilities? And how can ultimately one become a patient of yours?
Sure. Yeah. No, I only practice at a Yale, locally in Connecticut, 2 different sides of Connecticut, but we had the opportunity to do a lot of virtual visits, which are challenging, of course, because they don't really tell the story. But I think I see maybe some people on the call or on the talk that I might have met during COVID, which was kind of cool. People who were maybe like thinking about getting a joint replacement, and some people have certainly come up to Connecticut to meet us. Yeah, I mean, right now it's just not clear what the COVID restrictions are on being able to see people virtually and things like that. But, you know, if you come to New York and you just come drive an hour north, then I'll be waiting for you.
Sure. Can someone see you if they're located out of state from a virtual perspective? I know that sometimes that
that's a good question. I can probably get that answer. I think the official answer is that you have to be in Connecticut. Whether you wink after that or not is up to you. But officially, you have to be within Connecticut borders for insurance purposes.
Okay. From a high level, what got you interested in starting your work with adults with AMC?
Yeah, it's a great question. So I got into orthopedics for a variety of reasons, and I was very interested in cerebral palsy because of just some people I knew. And then I was doing this limb deformity traveling fellowship, and I stumbled upon this guy at the Philadelphia Shriners who knew a little bit about arthrogryposis, and I spent 2 days having Harold Van Bossy talk all about arthrogryposis. And I knew arthrogryposis because I had treated it in the past, but just spending time with him made me so passionate about it. Because if you think about it, the way that we were treating it at least 5 years ago, like for the knee, for example, right? It's the perfect combination of the things you learn in spasticity disorders like cerebral palsy and the things you learn in limb deformity disorders. It's like the perfect marriage of that two. But then when I started meeting more of the patients and talking to them, and I realized just how resilient, smart, and just amazing they were, it was like, it was heaven. So my favorite patients that I take care of, many of them have arthrogryposis. I have many things I could have talked about that are really out of the box that are done. There's a lot of things that adults need to either correct problems that were developed in childhood. But I think the biggest thing about it is that you really have to use all the concepts you have, lean on people like Harold and David and other people who have a lot of experience. Even Dan Zlotlo, when I was just like a new attending, I sent him an email just out of the blue, like, hey man, like, what would you do for this? And he sent me back all this data and things I should do. It doesn't even know me. So it's a nice community. But yeah, I think to answer the question, that's what got me into it. And I think the idea that it's a goal-oriented disorder, right? If someone comes into the office because they're in college and they realize that they just can't stand in their organic chemistry lab and they want to defer it for a year and try to clean up that little bit of contracture that they had coming out of childhood, that's a goal we can fix. If someone has arthritis or something, we can fix it. So I think it's more, if you have the psychological and mental capacity to push yourself, then you're the best patient ever to treat, right? So
sure.
I don't know if I can talk for hours. I don't know if that's
no, yeah,
question. Sorry.
Perfect. Two more like comments that kind of go along with that. Can you, one, tell more of your friends to specialize in this too? And then they just really wanted to sincerely tell you how much they appreciate you and all that you've brought to this conversation. There was a slide when you were talking about hips, and there are 4 doctors on the screen. Did all of those doctors treat AMCers? And if so, I think we have several people that want to go back and kind of screenshot that slide so they can
Oh yeah.
see those
So
names.
yeah, so those are my partners. Two of them are really talented hip surgeons. Sorry, three of them are really talented hip surgeons, and one's a fantastic physiatrist. And with those people, we can troubleshoot most problems. And again, there's no research. I can't spend enough time on this. The only way we could get research is, unfortunately, just looking at other disorders that are similar, which we know that they're not. This is an entity that is not the same. But if we look at, let's say, the hip and arthritis and people who have X disorder, if there's been a paper on it and they do well with some treatment, then we say, we'll do this treatment and maybe it'll work. So a lot of it is really doing what we believe is right, with the understanding that first, we do no harm. And it's really fun for me to talk to those people and give them advice. And actually, doctors, like, I'm pretty young in my career, honestly, and like some big wig hip surgeon is calling me from a big place just to like say, hey, what do I need to know about arthrogryposis? It's like, oh, how much time do you have? So I think if you have people who've done surgeries or have some experience with the population, it goes a long way. But like we said before, we do need to expand the workforce too. So like if someone needs a hip replacement and I look at their x-rays and I look at them and it's pretty straightforward, you can get that done near your house where you'll do better. Some people do not have straightforward problems, or they actually want to travel. And we do some hip surgeries here at Yale where you like go home the same day. So it's not what it used to be. And it's a different sort of operation. Like a lot of my partners do it from different approaches. It's just, we could talk for a while about it.
Awesome. Do you have any counterparts or people that you'd recommend who treat adults on the West Coast?
Yeah, it's a great question. So one of the aforementioned hip surgeons, I got to find out if that patient had her total hip in Los Angeles, but I personally don't know anyone on the West Coast that is in the adult world. A lot of the success we've had is with pediatric doctors who see adults or in a private institution that allows them to see adults. So we've had some success with that. I would say that as individuals get more involved and have the ability to do adult clinics, then one of the things I'm doing is, so in the cerebral palsy world, there's a huge drive for people to do like these lifespan clinics and do adults. And so a lot of those doctors are pediatric doctors that for whatever reason also like to treat AMC. So maybe it's the contracture work or whatever it is, even though we view it as a totally different treatment. If you listen to Dr. Feldman, he taught me that. So, but those are very similar doctors that do that. And so whenever I see someone who has an adult CP clinic, I always say, hey man, you treating arthrogryposis? So I'm trying to find them. So sit tight or fly east, but we'll find them. We'll expand the workforce. It's mandatory.
I appreciate that. Another comment that I think you'll appreciate, be careful, because when you make it to conference, you're going to get several hugs from this community. They're all so thankful for you. Another, I think, fairly straightforward question. With a hip out of socket and someone lays down, they get pain that seems to travel along their sartorius muscle. Is that right? And she gets relief by having the leg pulled up. I'm not sure of the actual question there, but if you want to talk through, I guess, that experience, if you have any advice. Yeah,
it's tricky. So, I think I can understand what you're doing, and without trying to diagnose you, I'll say that pain, the classic mantra is that pain coming from the inside of the hip joint is really experienced in the groin. So one of the best ways we can differentiate that a lot of the pain is actually coming from the inside of the hip is because you experience it as groin pain, as opposed to like on the side of your hip or in the back of your hip. Classically, that would be maybe coming from the back or somewhere that hurts when you press. If you have a dislocated hip and the pain travels down kind of the inside, it could be the dislocation that's hurting you. It's tricky because I don't know if you have amyoplasia or what the underlying muscle strength and coordination is. So it's not a one size fits all kind of answer. And I know you know that, but it's tough to say exactly what the problem is, but I'll just give you an example. If someone has a dislocated hip, which is experienced quite a bit, and a lot of those folks are still ambulatory and doing great. But if there is some pain there, then one of the best things we can do is an injection into the hip, some numbing medicine, maybe some steroid, and just see if the pain goes away even temporarily. So if your pain is coming from the inside, then we might be able to get a little bit of pain relief with an injection, which is a nice diagnostic test for us, because then we say, okay, this is where the pain is. If it doesn't relieve it, then we have to look for other sources. Is that muscle tight? Is that muscle spasming? You know, it could be a lot of things. Is it a nerve? So there's a lot of reasons.
Awesome. This next question comes from an adult with amyoplasia in their 50s. I had a hip replacement less than a year ago. The middle part of the hip replacement in my femur is now loose. Will it cause more trouble if I wait for the revision?
Yeah, so loosening is a problem. I will say that it is not a problem that is specific to arthrogryposis. So I'm not a joint replacement surgeon, but I know that loosening is something that is typically addressed, and you have this, your surgeon will have to rule out or rule in the reason why it got loose. One of the things, just from a technical perspective, is that some people with arthrogryposis are very stiff in the hip, or the hip is developed kind of inappropriately. So sometimes you can't put the components in the anatomically perfect location, and that we think that's okay. So for example, if you are missing, part of your cup and it's deficient in one way, but your joint is so tight that it hardly moves, and you can kind of stuff a hip in there for pain management, we think that's okay, because you're not going to put your range of motion in such a place that you'll dislocate the hip. But if the forces are abnormal, certainly you could get loosening, but there are a lot of other reasons to get loosening, like infection and things like that. So I can't answer the question, unfortunately, totally, but most likely a surgeon put your hip in that does a lot of total hips, and there's a lot to say for that. That's why I did a couple when I started and realized I wasn't doing 10 a week, so I stopped. And so I have people who can do it a lot better. So I'm sure your surgeon can work through that.
To dive a little bit deeper into hips, can you talk about any complications for hip replacements with AMCers? And then is there anything that you think would prohibit one from actually going through with an actual replacement, I guess?
Yeah, so specific to arthrogryposis, really it's the variable level of stiffness and the variable level of muscle control. So your hip is a joint that when you put in a joint replacement, you need it to remain stable, meaning you don't want, for example, if I did a hip replacement, I wouldn't want the femur to dislocate off the socket. That would be very bad. So what keeps it there is a combination of the soft tissues, like the remaining joint capsule, but mainly and also the geometry of the bone, but also the muscles that span that joint. So if you have a disorder that makes the muscles less predictable, maybe a little bit weaker, some of them tight, some of them loose, some of them strong, some of them weak, then achieving the balance that you need to keep the hip in the socket may be a little more challenging. If you add on top of that the joint itself may not have so much space and may be tight, then you lead to a situation where your rehab can be a little bit less predictable. Our experience with arthrogryposis is that the surgery is technically very difficult sometimes, but the postoperative course is actually pretty straightforward. The first thing people notice is that they can stand up with significantly less pain. That is actually something that we see. And again, this is all anecdotal. It has not been reported. There have been some small studies on total hips where they talk about like 5 patients, 6 patients. But either way, there's a lot of different technical things, but at the end of the day, the risks that people without arthrogryposis have, those still exist. Now, I will also comment that some people with arthrogryposis do have urinary concerns. So if you are someone that cats or someone that has other, bladder considerations that may result in having like a urinary tract infection chronically, that does actually
Sure.
raise your risk of having an infection for a hip replacement, I believe. So that's something that, like, if you were going to have it done, you'd have to see urology, usually get things treated. So if you have other disorders that are, and then if you have arthrogryposis in the genetic variety where it affects a lot of different body systems, obviously you're going to want to address all those body systems before surgery as well. So sometimes it takes a lot of
Sure.
coordination.
Sure. To dive into the stat that you gave about only operating on about 2% of the adults that you see, is that because the risks are too great, or just because there are other options?
I think, and that's kind of top of the head. That was like on the spot. I gave a risk. The point that I'm trying to say, I didn't look at all my data and look at all the adults and say, like, I've only operated on 2%. So it may be a little higher. It's definitely lower than 10%. I'll tell you that much. And that's just because I think at this point, I'm very young in my career, and I don't have a nice orthopedic management of arthrogryposis over 18 textbook sitting on my bookshelf behind me, So I'm always thinking first, do no harm. I could always make somebody worse with surgery. And so, I kind of try. Now, if someone has a problem that's very functional and there's a remarkably good chance that I could improve that situation with surgery, then I'll offer that. But, like, for example, a woman that I took care of recently has a hand that has never pronated. So it's always stuck like this. And, she just got a job, but she's also like in her 20s. And so 20-year-olds don't care about having their hand like this. All they want to do is be able to, like, type and text and things like that. So we did a forearm rotation on her, just to bring her hand over. But she had to go through like an extensive evaluation with an OT and try to figure out what the perfect position of her hand was. And then we had to get CAT scans to do like a 3D printed thing. So, for her, it made sense to do surgery. But for the majority of people, it's more like trying to get to know them and really understand if their goals align with a surgical course of management. So it's hard for me to have the kind of practice where people fly in and I say, oh, yeah, you would do great with, if we did this crazy thing. We'll do it tomorrow. It's crazy to me. So maybe we'll get to the point where we have enough research, enough experience where I could say kind of with good certainty that someone would benefit from surgery. But for the most part, I think it's more of me being cautious, not knowing what the result is going to be. And then also that surgery is not always the answer, especially like the example I gave with the woman who needs her foot. So if I fused her ankle, she wouldn't be able to do what she really I would venture to say loves doing at that moment more than anything else in the world, right? Feeding her grandkid, her first grandkid. So, yeah.
Awesome. Can we talk a little bit more about steroid injections in AMCers? One was told that it would not be a good idea because of other possible complications.
Yeah, so steroid injection is, the things that make it dangerous are like concomitant disorders. So if you have diabetes, it can raise your sugars. There's some risk if you do steroid injections that it might not work. I think the risk of putting steroid into someone with AMC, in my opinion, like in a hip bursa or in an arthritic knee or in a painful ankle, the risks are no different from someone with the same problems minus AMC. So I don't think the arthrogryposis itself, in my opinion, for a single dose of steroid, unless you have some other risk factor, right? So if you have some propensity to have a problem with steroid, then I wouldn't do it. To my knowledge, there's no data. I could be wrong, but to my knowledge, nothing showing that, for example, like giving a steroid injection is going to cause a neuropathy or muscle weakness or things like that. So I'm talking specifically about injecting it into joints or injecting it into inflamed spaces.
Great. To go back to knees, when can an adult with AMC have a knee replacement surgery, and how long does that last, and how often, if ever, would it need to be repeated?
Yeah, it's a good question. So like when I was training, which was, I don't know, 10 years ago or something like that, there used to be this mantra that your knee replacement will last 15 years, and then it'll need to be replaced after that And then the revision will last half that time, and every subsequent revision will last half that time. And so you're like, if you did the math and you looked at the logarithmic scale, you could like you can't have a knee after whatever, 24 years or something like that. So
Sure.
we know now that a lot of the reasons for failure, a lot of the implants have been redesigned. It also, again, depends on your demand. So I have some AMC young adults who go rock climbing and do crazy things, like motocross and stuff like that. You get a knee replacement and you're going to beat the heck out of it. You're going to need it revised. If you are somebody who, I've seen this as well, who has extension contractures and your knee ranges 30 degrees, you're going to have a remarkably challenging knee replacement to do to begin with, but also the demand you're placing across the knee is actually not as much as you think. So if your knee doesn't bend that much and you're using it really to walk around the house, or maybe, relatively short distances, then you're probably not going to beat up the knee itself. So in a lot of cases, what we worry about in the long term is the implants getting loose, or the plastic. So the knee replacements are usually metal top, metal bottom, and some plastic on the inside. There's some differences nowadays too, but in general, you wear out the plastic. That's like the thing that happens. And so you maybe be able to replace the plastic, but we're using different plastics. I mean, I don't know as much about this kind of stuff anymore than I used to, but my partners do. And I think now knee replacements last significantly longer. I think if you're someone who's very high demand, then you're going to be at risk for needing a revision. The other thing that we do a lot here at Yale are partial knee replacements. So if you just have like 1/3 of the knee is not so good and it's not salvageable, then you could just replace kind of that one little part. There's some patient specific stuff that my partners do that I think is really cool. And then remember that if you have arthritis because you're overloading one side from a residual deformity, sometimes actually correcting the deformity can take away a lot of your pain too. So there is still a role for osteotomy and things like that. And in adult, a lot of us get a lot of folks with AMC get like a little shiver when they hear osteotomy because they think back to childhood and things like that. But the truth is that pain management has come a long way as well. So I would say almost every osteotomy we do now has some kind of nerve block, and we have great teams that can find nerves even when the muscles kind of don't exist the way they should. And an anesthesiologist puts a ultrasound probe up against your skin but doesn't see like a perfect muscle outline next to the nerve, then understanding the anatomy and not saying, no, I won't do this nerve block, they'll actually give it a try or call in someone better. So there are a lot better ways to experience these procedures nowadays. But at the end of the day, it's all about mobility, the loss of whatever function you have worked so hard your whole childhood to attain. Those are the things that we're interested about.
Sure. We had a parent ask just around like the long term of their child with myoplegia at this point. Any advice on steps that they can take now to avoid pain in adulthood?
Yeah, it's a good question. So, this is like the depressing thing to say. With a lot of disorders, especially spasticity disorders that cause abnormal muscle tone, it seems to be that pain, especially ankle pain, some back pain, it seems to be inherent to the disorder. So like it will be experienced. And I get heartbreaking emails sometimes or messages on the patient portal from some of my patients that are adults with AMC. I have kids, I'm doing great. Surgery was great, or like the injection worked perfectly, but I still have this fatigue and it's like central pain. So pain disorders are pretty common. I don't have a great solution for them as a surgeon. We have pain management people that are pretty good. A lot of it we know nowadays can be psychoactive. So there is some anxiety, depression, things like that lead to pain. And those are real lived experiences that can't be taken lightly. But as a parent, I would not change the way I had treatments for my child in 2021 in hopes to relieve pain in the future. we know some things are painful, like for example, untreated club foot is going to lead to a painful foot, but having perfect treatments and perfect alignment, we don't know why somehow that results in some people as a pain experience. So I can't give you good advice right now, unfortunately, on how to prevent that experience. It just seems to be a lived experience that is more common than we would like. But again, with research, we can maybe do some correlation, try to figure out why are some people having more pain than others? Is it nerve dysfunction? Is it people with a specific genotype that led to AMC? So there's more questions than answers, unfortunately, in 2020.
Sure. To quickly segue into that concept of doing research, are you conducting any at the moment? And if you are, how can our viewers get involved? And then I guess, or do you know of any studies that are being done that ultimately we can take advantage of?
Yeah, a lot of the studies that I showed were from one or two centers. So Dr. Hall, there's like the same couple of centers in
Sure.
Canada. And so I'm sure that, what would be really great is if we all kind of bothered Harold to see if we could get more of his long-term data. That would probably be the ideal. Because, between those two ex-New York University faculty members, Dr. Feldman and Dr. Van Bassa, we have like millions, right? We have so many people with AMC that they've treated. It'd be really great to do some kind of callback, get them signed up in AMCSI, and then just survey them, right? So the best way to do it is long-term. And you can't really start doing research unless you know the natural history. So you look at people with untreated AMC or opted to not treat certain aspects of AMC. Now, untreated AMC is a bad term. I apologize for using that. But if there are reasons why people do not treat certain things that happen with AMC, what happens to them? Like why are we treating clubfoot? Do we think that clubfoot and AMC, if untreated, is going to be really bad? Well, we have enough data, not in AMC, that says, yes, it is pretty bad for you in the future. It causes pain, disability, things like that. We don't have that data for, let's say, like mild back pain. So if someone has mild back pain in their teenage years, I'm just like thinking of something. Does that mean that later on they're going to have like crippling back pain that prevents them from working? So we don't know.
Sure.
I do think that the learned resiliency of the general person with amyoplasia and what you have to go through as a young child, often during ages where it seems punitive, like, what did they do to deserve having these casts on, things like that. It changes you as a person somehow that I haven't quite figured out. And I think that kids with AMC who have to go through that stuff have some truly amazing parents. And doctors and nurses and providers who fight for them along the way. And so,
Absolutely.
You need that stuff as an adult too. But again, so I would love to be doing research. I just don't see enough patients at this point. One thing that we could do is survey people. It's a little less accurate, but again, like that study I first showed how are adults doing. That's the first step. How are we doing now? What are the problems we need to know? I put up a slide with a list of all the different concerns. How do we address those things? Which ones are really affecting people's lives? And most importantly, people with AMC, which of these are important to you? Because like some guy sitting in an office, like telling you what's wrong with you and telling you what needs to be fixed, that's not useful. It's really what's meaningful to you and how can we help you change that?
Yeah, I so appreciate you incorporating the social emotional aspects of life and all that comes along with that in those questions. So truly appreciate that. Another question around just your work with other doctors, in particular, those who are treating children with AMC. Have you talked to them about, the potential consequences that may come later in life with some of the decisions that they're making or early on in treatment? This person said that they just wish that their doctor had sort of been more aware of the issues that she is now facing and potentially made certain choices a little bit differently when she was younger.
Yeah, I thank you for sharing that experience of the person asking the question. The truth is that your doctor may not have known, your doctor may not have done probably didn't do the wrong thing, like I still don't know what the ultimate fate of some of the hips that I operate on in kids with AMC is going to be. Are they going to end up, yeah, it looks great when I'm there, right? Or maybe not so great, or, but maybe the surgery goes well, the recovery goes well, the kid's doing great. Are they going to end up with a hip replacement? I don't know what the story is. So again, we don't know what percentage of people with certain phenotypes are going to end up in some way. We just don't have that information yet. So, I wouldn't say that your doctor, I don't know your age, but like, let's say you're over 30. I don't know that your doctor, let's say 20 years ago, had any even inkling that this was the wrong thing to do. Sure. Unfortunately, you didn't have a perfect experience, but you are certainly not alone. And we're working on it for you.
Yeah. We are all out of time for questions, but there's one more comment I wanted to read. This person says, thank you so much for all the work that you've done in forming these theories. I felt just abandoned by research for so long. No one has answers because no one is asking these questions. Truly appreciate you taking the time to consider and think about what is happening to adults.
Oh, it's very nice of you. Yeah. I mean, there's a lot of really great people that are part of this organization and are reached by it. I met one woman who only knew to talk to the organization because she saw a Facebook post by another member, just like talking about, I think it was, I don't know if I could say these names, but the person who posted on Facebook is this woman, Tracy, who I follow, and she's awesome because she posts things like, I think the 100 days leading up to AMC Day. She just gives little pointers. And the one that resonated with this one patient of mine, I'm sorry, I know we might be out of time, but I got to tell the story. The one that resonated was this woman, she posted on one of the days that like, hey, there's this thing that exists called a vein finder. If you have AMC, you might not have juicy veins that vampires like. So you should ask the anesthesiologist or the blood draw person, do you have a vein finder? If not, where can I go to have this? So that instead of having like 20 sticks to get blood, it's just one. And this woman was scared to come to see somebody about her knee problem, just specifically because she was scared she was going to be told she needed surgery. Then she would get poked like 1,000 times to find a vein, and she knows she doesn't have good veins. So the only way that she was able to get treatment for her patella disorder is very specifically getting this information. And it may seem very silly, but there's so many people who don't even know this conference exists, that and this organization exists. So I think just getting the word out there, wearing blue in June, these little things, just making people know that there's a huge community so that they get access to information. I'm not even talking about treatment. I'm just talking about like support and information. So keep putting it out there. Awareness is huge. So I appreciate everybody's work with that.
Yeah, I mean, so much of that is because of people like you who are willing to sort of take a chance on a random nonprofit and share all of your thoughts and take time out of your Friday night to share everything. So truly thankful for this opportunity. We are all wrapped up for the evening. Again, truly want to thank you for the opportunity to connect and taking time out of your Friday night to give us all of your thoughts and catch us up to date on all the things you're doing over at Yale. Truly wonderful to have this conversation.
Thanks for having me. Thank you again, everybody. Have a great time. Tomorrow, don't forget tomorrow. Got big doings.
Thanks for that plug. You are already doing it. You can be a spokesperson anytime you want. We're excited to have you. Gene, do you want to take it, or should I take it?
I am. I'm going to put it up on the screen, Joey, so that you can take it away and remind our audience to come back tomorrow.
Awesome. Guys, thank you so much for joining us today. Tomorrow is the big event that I've been waiting for all week to find out, where we're going in the coming year. This is, such a wonderful, I think, time to see our network in action. The number of people that it took to get this one presentation day up and going, insane. The number of people that have had their hand in making this week possible. Insane. It all truly centers around us wanting to come together to do right by this community that we all love so much. So thank you all for coming tonight. We have two really great speakers tomorrow before the closing ceremony. So don't forget to come watch and be a part of it. Appreciate all of you for coming, and so excited to have had this opportunity to meet these two wonderful doctors.
All righty. Thank you so much, Joey. So just like that, folks, it's a wrap for day 6. Remember, these sessions will be posted on the AMCS website and YouTube channel after our live virtual conference concludes this week. So we'll go ahead and say good night to each and every one of you and express our thanks for those of you joining us. So please be sure to look in the lower corner for that red leave button and to leave tonight's live session, and hopefully we'll see you all here tomorrow. And let's play our favorite song while we're waiting for our guests to leave.